The elbow joint is a hinge type of synovial joint, and it's actually made up of two separate joints which work together as one. The first joint, called the humero-ulnar joint, is between the trochlea of the humerus and the trochlear notch of the ulna, and the second one, called the humero-radial joint, is situated between the capitulum of the humerus and the superior aspect of the head of the radius. A good way to remember this is thinking of the crazy tulips. The CRA in crazy represents the capitulum, which articulates with the radius, and the TUL in tulips represents the trochlea, which articulates with the ulna. The elbow joint is covered by a synovial membrane, which is surrounded by a joint capsule. The joint capsule extends from the margins of the articular surfaces of the capitulum and trochlea on the humerus to the coronoid process anteriorly and to the olecranon fossa posteriorly. On both the medial and lateral sides, the elbow joint is strengthened by two strong ligaments called the collateral ligaments, which are thickenings of the elbow joint capsule. On the medial side, also called the ulnar side, there's the ulnar collateral ligament, which extends from the medial epicondyle of the humerus to the coronoid process and the olecranon of the ulna. The ulnar collateral ligament actually consists of three separate bands: anterior, posterior, and oblique. The anterior band is the strongest, and it runs from the medial epicondyle to the tubercle of the coronoid process. This band helps limit elbow extension. Next, there's the fan-shaped posterior band, the weakest of all, and it runs from the medial epicondyle to the olecranon of the ulna. This helps limit elbow flexion. Finally, there is the thin oblique band, which makes the socket for the trochlea slightly deeper, reducing the chance of dislocation. On the lateral side, there's the radial collateral ligament, which extends from the lateral epicondyle of the humerus to the annular ligament which it blends with. The annular ligament encircles the radial head and binds it into the radial notch of the ulna, allowing for pronation and supination of the forearm. Now, the elbow joint is also surrounded by synovial fluid-filled bursae, which are basically pockets of synovial fluid that provide lubrication and reduce the friction when structures such as tendons, skin, muscles, and bones rub against each other with movement. There are three main elbow bursae. First, there's the subcutaneous olecranon bursa, which lies between the olecranon and the subcutaneous tissue. Then, the subtendinous olecranon bursa, situated between the tip of the olecranon and the triceps brachii tendon. And third, there's the intratendinous olecranon bursa, which lies within the triceps brachii tendon at the point of its insertion onto the olecranon. Finally, another important bursa, called the bicipido-radial bursa, is situated in the cubital fossa, which is a small, fat-filled, triangular space on the anterior aspect of the elbow. Specifically, the bicipido-radial bursa is situated between biceps brachii tendon and the tuberosity of the radius. As a hinge-type synovial joint, the elbow can do only two types of movements. That's what any hinge does, right? It opens and closes. The same goes for the elbow. This joint extends and flexes. Extension is mainly done by the triceps brachii, while flexion is mainly done by the brachialis and the biceps brachii muscles. The elbow joint receives its blood supply from the elbow's periarticular anastomosis, formed by the branches of the collateral and recurrent branches of the brachial artery, as well as the profunda brachii and the radial and ulnar arteries. Finally, regarding innervation, remember Hilton's law, which says that the nerves that innervate the muscles crossing over a particular joint also innervate that joint. So according to Hilton's law, the elbow joint is innervated by three nerves: the musculocutaneous nerve, the radial nerve, and the ulnar nerve. Before we wrap up, feel free to hit the pause button and see if you can remember the bands of the ulnar collateral ligament. Hint, there are three of them. Alright, as a quick recap, the elbow joint is a hinge-type synovial joint which allows flexion and extension of the elbow. On both the medial and lateral sides, the elbow joint is strengthened by the ulnar and radial collateral ligaments, respectively, which are thickenings of the elbow joint capsule that provide stability to the elbow joint. There are three main elbow bursae: the subcutaneous olecranon bursa, the subtendinous olecranon bursa, and the intratendinous olecranon bursa. Blood supply for the elbow joint comes from the periarticular anastomosis, while innervation is handled by the musculocutaneous, radial, and ulnar nerve.
The axilla, also known as the armpit, is first and foremost incredibly ticklish. But from an anatomical standpoint, it's a key location that contains many important structures that may be damaged, causing significant functional deficits. The axilla is like a train station, where a number of vascular, nervous, and lymphatic structures pass between the trunk and the upper limb. One very important structure is the brachial plexus, which can be divided into 5 roots, 3 trunks, 6 divisions, 3 anterior and 3 posterior cords, and 5 terminal branches. The order can be remembered using the mnemonic, "Remember to drink cold beer." But you may want to wait until at least the end of the video before you act on that. Now, an upper brachial plexus injury affects the superior root, namely spinal nerves C5 and C6, and a classic example of an upper brachial plexus injury is Erb palsy, which can happen in adults as a shoulder trauma that results in an increase in the angle between the neck and the shoulder, or in newborns, when excessive stretching of the neck occurs during childbirth. The clinical consequences reflect the affected nerves, which are the ones that are derived solely from C5 and C6 roots, namely the musculocutaneous, axillary, and suprascapular nerves. This causes paralysis of muscles like the biceps brachii, which normally allows forearm flexion and supination, and the infraspinatus and teres minor, so lateral rotation of the arm is affected, as well as the deltoid and supraspinatus muscles, which would usually cause arm abduction but would also be affected. So, with superior brachial plexus injuries, the classic finding is a waiter's tip position, which reflects arm adduction and medial rotation, and forearm extension and pronation. Lower brachial plexus injuries are much more uncommon, and they affect the interior roots of the brachial plexus, namely C8 and T1. This can happen because of excessive abduction of the arm, aka an increased angle between the trunk and the upper limb. This could happen to a person falling from a tree and grabbing onto a branch, or during delivery if the newborn is pulled out by the arm. The result is what's clinically known as Klumpke palsy, which has serious effects on nerves derived from the C8 and T1 roots, like the median and ulnar nerves, and causes loss of sensation along the medial side of the arm, and paralysis of the intrinsic hand muscles. The classic finding is a claw hand, which is due to flexion of the interphalangeal joints and extension of the metacarpophalangeal or MCP joints. This is mainly due to paralysis of the lumbricals, which normally act to flex the MCP joints and extend the interphalangeal joints as if you were to be waving bye-bye, resulting in unopposed flexion of the interphalangeal joints and unopposed extension of the MCP joints. Lower brachial plexus injuries can also occur due to compression of the lower trunk, for example, by an extra or cervical rib, or by an apical lung tumor called a Pancoast tumor. This is an example of thoracic outlet syndrome and results in the same deficits as seen in Klumpke palsy. However, thoracic outlet syndrome can also result from damage to any structures that enter and exit the lower neck and upper limbs via the superior thoracic aperture, which is the region above the first rib between the clavicle, sternum, and cervical vertebrae. These structures include the subclavian vessels, which are usually compressed in the scalene triangle, formed by the anterior and middle scalene muscles. The brachial plexus trunks, along with the subclavian artery, pass through this scalene triangle, where the subclavian vein travels anterior to it. Compression of the subclavian vessels results in upper extremity swelling and exertional arm pain. And speaking of compression, the radial nerve can also be affected by compression injuries. This happens when the radial nerve is compressed against the hard surface of the humerus, often occurring when we are sitting down and have our arms spread out over a chair next to us. This is commonly referred to as Saturday night palsy because it might happen on a Saturday night if you fall asleep with your arm hanging over the chair. But it can also happen from any direct pressure on the radial nerve, for example, when using crutches. Spending an extensive amount of time in that position can cause weakness in elbow extension and wrist extension, classically known as wrist drop, in addition to loss of sensation over the dorsal hand and thumb, as well as the posterior forearm or arm, depending on how high up the nerve damage is. Finally, the axilla is also home to the axillary lymph nodes, which are often dissected and sent for pathologic analysis in the evaluation of breast cancer. Axillary nerve dissection, however, comes with a risk of long thoracic nerve injury, which clinically translates as a winged scapula. A winged scapula is more apparent when a person tries to push against a wall. The medial border and inferior angle of the scapula pull away from the posterior thoracic wall, making the scapula look like a wing. Besides protracting the scapula against the posterior thoracic wall, the serratus anterior also helps abduct the arm above the horizontal plane, so patients may have trouble doing overhead movements, like, for example, brushing their hair. Alright, as a quick recap. Superior brachial plexus injuries cause Erb palsy, and the classic finding is a waiter's tip position, which reflects arm adduction and medial rotation, as well as forearm extension and pronation. Inferior brachial plexus injuries cause Klumpke palsy, and the classic finding is a claw hand due to flexion of the interphalangeal joints and extension of the metacarpophalangeal joints. Compression of structures at the superior thoracic aperture can result in superior thoracic outlet syndrome, which often affects the lower trunks of the brachial plexus or subclavian vessels. Compression of the axilla can result in radial nerve palsy, resulting in wrist drop. Finally, the axilla is also home to the axillary lymph nodes, and during axillary lymph node dissection, damage to the long thoracic nerve may result in a winged scapula.
The vertebral column, commonly referred to as the spine or spinal column, consists of 33 vertebrae organized in 5 main regions: 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. The vertebrae come in different shapes and sizes, and they have unique features depending on their region. Typical vertebrae have a basic structure in common, consisting of a vertebral body, a vertebral arch, and 7 processes: a spinous process, 2 transverse processes, and 2 superior and 2 inferior articular processes. The vertebral body is the thick, cylindrical anterior portion of the vertebra, which functions in supporting weight. As you move down the spine, the vertebral bodies become larger as they bear more weight. Posterior to the vertebral body, there is the vertebral arch, which consists of 2 pedicles and 2 laminae. The pedicles are short, thick processes that project posteriorly from the vertebral body to meet the laminae, which are 2 broad, flat plates of bone that unite in the midline and complete the vertebral arch. The space between the walls of the vertebral arch and the vertebral body is called the vertebral foramen, and when you stack all the foramina on top of each other, that forms the vertebral or spinal canal, which forms a protective bony case around the spinal cord. Focusing on the 7 processes of the vertebrae, first we have the spinous process, which extends posteriorly from the midline junction of the laminae and serves as an attachment site for ligaments and muscles. Next, the left and right transverse processes. They extend posterolaterally from the junctions of the pedicles and laminae, while also serving as important attachment sites for ligaments and muscles. Finally, we have the 4 articular processes. First, there's the left and right superior articular processes, which project superiorly from the junctions of the pedicles and laminae. Next are the left and right inferior articular processes, which project inferiorly from the junctions of the pedicles and laminae. The superior articular processes, inferior articular processes, along with the pedicles, the vertebral bodies, and intervertebral discs between vertebral bodies go on to create U-shaped indentations called the superior and inferior vertebral notch. So let's look at the articulation between two typical vertebrae from a lateral angle. The superior and inferior articular processes of each vertebra allow articulation with adjacent vertebrae via their articular facets. The inferior articular process of the top vertebra comes into contact with the superior articular process of the bottom vertebra, forming a zygapophyseal joint, also called a facet joint. The facet joints help keep the vertebrae properly aligned while also allowing movement of the vertebral bodies. Furthermore, their orientation differs throughout the vertebral column. This allows for different movements of the vertebral bodies in the cervical, thoracic, and lumbar regions. While still looking from a lateral view, you can also see how the inferior vertebral notch of the vertebra on top aligns with the superior vertebral notch of the vertebra below it to form a canal called the intervertebral foramen, through which the spinal nerves pass. Okay, before moving on, let's take a short break and see if you can recall the basic features of a typical vertebra. So now let's look at the common features of the typical vertebrae in each region. Cervical vertebrae can be typical or atypical. And when it comes to the cervical column, the typical vertebrae are C3, C4, C5, and C6, while the atypical vertebrae are C1, C2, and C7. The vertebral bodies of typical cervical vertebrae are smaller than the other regions, are wider from side to side, and have a concave superior surface and a convex inferior surface. The lateral edges of the superior surface of the vertebral bodies are each called the uncus of the body or the uncinate process. Now, what really makes cervical vertebrae stand out is that they have a foramen transversarium, or transverse foramen, which is an opening on each of the transverse processes. It's through these foramina that the vertebral arteries and corresponding veins pass. The lateral ends of the transverse processes have two projections, an anterior tubercle and a posterior tubercle, which are attachment sites for the levator scapulae and scalene muscles. The vertebral foramen of the cervical vertebrae is large and triangular shaped to accommodate the cervical enlargement of the spinal cord to fit through it. The facets on cervical vertebrae are nearly horizontal and as such allow for the most movement of all vertebral regions. The superior articular facets are directed slightly supero-posteriorly, meaning the facets face up and back slightly, while the inferior articular facets are directed slightly inferiorly and anteriorly, meaning the facets face down and forward slightly. This allows adjacent cervical vertebrae to sit nicely upon each other. The main movements the facet joint allows in the cervical region are free flexion and extension, some lateral flexion, and limited rotation. The spinous process of the cervical vertebrae are short, where typically C2 through C6 are bifid, meaning they have two protrusions at the posterior end that project posterolaterally. But let's not forget about the atypical cervical vertebrae. First, the C1 vertebra, also called the atlas, is a ring-shaped bone that doesn't have a body or spinous process. So instead of a body, it has paired lateral masses that serve as a body and sustain the weight of the globe-like cranium, just like the Atlas of Greek mythology, who bore the weight of the literal world on his shoulders. The transverse processes of the atlas arise from the lateral masses, so these processes are placed more laterally than those of the inferior vertebrae. This makes the atlas the widest of the cervical vertebrae. Now, the lateral masses have two superior, concave, kidney-shaped articular surfaces. These surfaces articulate with two large cranial protuberances on either side of the foramen magnum on the occipital bone, called the occipital condyles, to form the atlanto-occipital joint. The anterior and posterior arches extend between the lateral masses and form a complete ring. The anterior arch has an anterior tubercle and a facet for the dens, and the posterior arch has a posterior tubercle and a groove for the vertebral artery. On the anterior arch, there's a tubercle for the transverse ligament. The transverse ligament extends from one lateral mass to the other lateral mass on the atlas, passing between the spinal cord and the dens, which is a part of the C2 vertebra. Speaking of which, the C2 vertebra is also called the axis because it has a blunt tooth-like dens or odontoid process. The dens projects superiorly and articulates with the posterior surface of the anterior arch of the atlas, and it's held in place by the transverse ligament. Next, C2 also has two large, flat, weight-bearing surfaces called the superior articular facets, on which the atlas rotates. It also has inferior articular processes and transverse processes similar to the other cervical vertebrae. Finally, C7 has a smaller transverse foramen than the other cervical vertebrae, and it's also called the vertebra prominens due to its long spinous process. In most people, it is the most prominent spinous process, and you can actually feel it if you run your finger and press along the midline of the back of your neck. Okay, I prominens we're done articulating the multifaceted details of the cervical vertebrae for now. Take a moment to see if you can recall the key structures of the typical and atypical cervical vertebrae. All right, next up are the thoracic vertebrae, which are located in the upper and middle back, between the cervical and lumbar vertebrae. They are intermediate in size, though they do get bigger further down the vertebral column. On a quick glance, an easy way to identify the thoracic vertebrae is from a posterior lateral view, where they look like a giraffe. This is compared to the lumbar vertebrae, which we will talk about shortly, which look like a moose. From a superior view, the typical thoracic vertebrae, which are T2 through T11, have a heart-shaped vertebral body, a vertebral foramen that is circular and small, and a pair of transverse processes that are long, strong, and extend posterolaterally. Let's look at a typical thoracic vertebra from a lateral view. The facets of the superior articular processes are nearly vertical and face posteriorly and slightly laterally, while the facets of the inferior articular processes are also nearly vertical, but face anteriorly and slightly medially. The unique orientation of the facets allows adjacent thoracic vertebrae to articulate nicely. This orientation also results in the main movement of rotation and some lateral flexion of the thoracic vertebrae. The spinous process of a typical thoracic vertebra is long and slopes postero-inferiorly, overlapping with the inferior vertebra. The most characteristic features of the thoracic vertebrae are the two superior and two inferior costal facets, which articulate with the heads of the ribs. These are known as demifacets, as they are half of a facet, with two demifacets articulating with the head of a single rib. There's also one costal facet on the anterior side of each of the transverse processes, called the transverse costal facet, which articulates with the tubercle of the ribs. And now, just a few words on the atypical thoracic vertebrae features, which are T1 and T12. T1 is similar to the C7 vertebra, so it has a long, nearly horizontal spinous process, similar to that of C7. Furthermore, the superior costal facet of T1 is a complete costal facet and not a demifacet when articulating with the first rib, where its inferior costal facet is a demifacet for the upper half of the head of the second rib. T12, on the other hand, has quite a bit in common with its downstairs neighbors, the lumbar vertebrae. Its upper half is more thoracic-like, having costal facets and articular processes that permit mainly rotational movements between it and the vertebrae above. Its lower half is more lumbar-like, with the body and pedicles being larger and thicker, as well as having a shorter, more horizontal spinous process. Furthermore, the inferior articular processes are more laterally facing, which means the movements between T12 and L1 are flexion and extension, not rotation. Since T12 is sort of caught in between the somewhat inflexible thoracic region and more flexible and mobile lumbar region, this vertebra is subject to increased transitional stress. This makes T12 the most commonly fractured vertebra. Okay, take a moment to see if you can recall the key structures of the typical and atypical thoracic vertebrae. All right, next up are the lumbar vertebrae, which are in the lower back, between the thoracic vertebrae and the sacrum. They are the largest movable vertebrae, which helps with bearing the weight of the upper body. They have a massive, thick, and strong body, which is fitting because, as we said before, from a posterior view, they look a lot like a moose, and that animal also has a massive, strong body. Typical lumbar vertebrae also have a triangle-shaped vertebral foramen, which is bigger than the thoracic vertebrae, but smaller than the cervical vertebrae. The lumbar vertebrae also have long, slender, transverse processes that extend laterally and short, broad, sturdy spinous processes. The superior articular facets are in the sagittal plane, mainly facing medially and a little posteriorly, while the inferior articular facets are also in the sagittal plane, mainly facing laterally and slightly anterior, allowing each lumbar vertebra to articulate well with the adjacent vertebrae. On the posterior surface of each of the superior articular processes, there are small tubercles called the mammillary processes that are characteristic of lumbar vertebrae. The mammillary processes project posteriorly and allow for attachment to the multifidus and intertransversarii muscles. There's another process called the accessory process, also characteristic of lumbar vertebrae, on the posterior surface of the base of each transverse process. The accessory process provides an attachment for the intertransversarii muscles. Now let's look at an atypical lumbar vertebra. Among the lumbar vertebrae, L5 is atypical in that it is the largest of the movable vertebrae, with the most massive body and transverse processes. This is because it carries the weight of the whole upper body. Its body is also taller anteriorly. Furthermore, the facets of the L5-S1 joint are more coronal in orientation, allowing for flexion and extension, along with some lateral flexion. Okay, let's stop moosing around and pause for a quick moment to see if you can recall the key structures of the typical and atypical lumbar vertebrae. All right, now let's look at the sacral region. The sacrum is a triangular bone made up of 5 fused sacral vertebrae in adults. It's located between the lumbar vertebrae and the coccyx in the vertebral column, right between the hip bones. It stabilizes the pelvis and transfers weight to the pelvic girdle. The sacrum is thick and wide across its base, where it plays a role in weight bearing, but it tapers down inferiorly towards its apex, where it does not bear weight. From an anterior view, we can see how the sacrum resulted from the fusion of the 5 sacral vertebrae, as we notice the 4 transverse ridges that indicate the divisions between what originally was the 5 individual sacral vertebrae, S1 through S5. The wide base of the sacrum is derived from S1, and on each side it extends laterally as a wing-like structure called the ala, which is Latin for wing. The anterior lip of the body of S1 is called the sacral promontory, which marks the border of the pelvic inlet. Inferiorly, we can see 4 pairs of anterior or ventral sacral foramina that lie lateral to each vertebral body and allow for the passage of the anterior rami of sacral spinal nerves. These foramina extend to the posterior aspect of the sacrum. From a posterior aspect, they are referred to as the posterior or dorsal sacral foramina. Also in the posterior view, we can see the superior articular processes of S1 and their corresponding superior articular facets on the dorsal aspect, which articulate with the inferior articular facets of L5 at the lumbosacral angle, which can vary between 130 and 160 degrees. The lateral surfaces of the superior half of the sacrum look a bit like ears and are aptly called the auricular surfaces. These auricular surfaces articulate with the ilium to form the sacroiliac joint. In the center of the sacrum, there's the sacral canal, which is the continuation of the vertebral canal. The sacral canal contains the spinal nerve roots that make up the cauda equina, the bundle of nerves protruding from the bottom of the spinal cord. Along the midline of the posterior surface of the sacrum is the medium sacral crest, which is the remnant of the fused spinous processes of S1 to S3, or sometimes S4. The intermediate sacral crests that lie just lateral to either side of the median crests are remnants of the fused articular processes of the sacral vertebrae. Finally, the lateral sacral crests lie further laterally on each side, and they arise as a result of fusion of the transverse processes of the sacral vertebrae. Because S5 doesn't have a spinous process, nor laminae, that results in an upside-down U-shaped opening in the wall of the sacral canal called the sacral hiatus. A bit further inferiorly, there are the sacral cornua, a pair of projections just lateral of the midline, which are remnants of the inferior articular processes of the S5 vertebra. And finally, there's the coccyx, or tailbone, which is a small, triangle-shaped bone derived from the fusion of the 4 rudimentary coccygeal vertebrae at the very bottom of the vertebral column. The anterior surface of the coccyx is smooth and slightly concave. The posterior surface is convex and has rudimentary articular processes. The coccyx serves as a site for attachment for parts of the gluteus maximus, coccygeus muscles, and the anococcygeal ligament. Whew, that was a lot. Take a short break and see if you can recall the key features of the sacrum and the coccyx. All right, as a quick recap, the vertebral column consists of 33 vertebrae organized into 5 regions, with 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. Generally speaking, the vertebrae across the different regions have some key components in common, including the vertebral body, pedicles, laminae, transverse processes, articular processes, and a spinous process. Cervical vertebrae are the smallest movable vertebrae with rectangular vertebral bodies, large triangle-shaped vertebral foramen, bifid spinous processes, and a pair of transverse foramina, which are specific to the region. The atypical cervical vertebrae are C1, the atlas, C2, the axis, and C7, the vertebra prominens. Thoracic vertebrae are a bit bigger than cervical vertebrae and increase in size down the column. They look like giraffes and have a heart-shaped vertebral body, a small circular vertebral foramen, long transverse processes, downward sloping spinous processes, and costal facets on the vertebral bodies and transverse processes, which are unique to the region. The atypical thoracic vertebrae are T1 at the top of the region, which appears to be more cervical-like, and T12 at the bottom of the region, which appears to be more lumbar-like. Lumbar vertebrae are the largest and strongest movable vertebrae, which is important since they bear the most weight, and remember, they look like a moose. They have distinctly massive vertebral bodies, medium-sized triangular vertebral foramen, slender transverse processes, and mammillary processes characteristic of the region. L5 is the lone atypical lumbar vertebra, with its massive body that is taller anteriorly, accounting for the lumbosacral angle. The sacrum and coccyx are the triangle-shaped bones at the bottom of the column that form from the fusion of the individual vertebrae that make them up.
The pelvic girdle, or the bony pelvis, is a bony ring formed by the left and right hip bones and the sacrum, and it surrounds the pelvic cavity and connects the vertebral column to the lower limbs. The main function of the pelvic girdle are to transfer the weight of the upper body to the lower limbs
when sitting or standing and provide attachment points for muscles that help with locomotion and posture. It also provides support and protection for the abdominopelvic structures. So let's start with the hip bones. The right and left hip bones are irregular shaped bones located at the sides of the pelvic cavity, which bound and form the lateral walls of the pelvis. Each one of these hip bones developed from the fusion of three bones: the ilium, ischium, and pubis. Now let's start with the upper part of the hip bone, the ilium. You can think of the ilium as a fan. It has an upper expanded part representing the spread of the fan, called the ala, and a lower narrow part representing the handle of the fan, called the body. Now, there are 4 bumps coming off the ilium called spines. Let's talk about them. If we look anteriorly to the ilium, we can see 2 of the spines. One of them is superior, and the other one is inferior. The naming is easy because it follows the rule of anterior or posterior plus superior or inferior. The superior one is called the anterior superior iliac spine, and the inferior one is called, you guessed it, the anterior inferior iliac spine. Now, looking at the ilium from a posterior view, we can see the remaining 2 spines, one superior and, again, one inferior. If we follow the rule just mentioned, we can name them easily. The superior one is called the posterior superior iliac spine, and the inferior one is called, wait for it, posterior inferior iliac spine. The main function of the spines is to provide attachment points for various muscles. For example, the longest muscle in the body is called the sartorius, and it attaches to the anterior superior iliac spine. Now, let's move to the next part of the ilium, the iliac crest, which is the rough, curved uppermost part of the ilium, representing the rim of the fan. The iliac crest runs between the anterior superior iliac spine and the posterior superior iliac spine. Now, when looking at the anteromedial surface of the ilium, we can see a fossa called the iliac fossa. This fossa is covered by a muscle called the iliacus. From a posteromedial view, we can see the auricular surface of the ilium. Right and left auricular surfaces of both ilia articulate with the sacrum, forming 2 sacroiliac joints. Above the auricular surface, there's an even rougher bit of bone called the iliac tuberosity, which has synovial and syndesmotic articulation with the reciprocal surface of the sacrum. Posteriorly, the ilium presents the gluteal surface. This surface is covered by 3 muscles called gluteus muscles. These muscles originate from lines on the gluteal surface of the ilium called posterior, anterior, and inferior gluteal lines. The gluteus minimus originates between the anterior and inferior gluteal lines. The gluteus medius originates between the anterior and posterior gluteal lines. And finally, the posterior gluteal line forms part of the origin of the gluteus maximus, which is the largest of the gluteal muscles. Moving on to the next part of the hip bone, the ischium. The ischium has 2 main parts, a body and a ramus. The body is the superior expanded part of the ischium that connects to the ilium superiorly and to the pubis anteriorly, and helps to form the acetabulum. The ramus is the lower, narrow part of the ischium that connects anteriorly to the lower part of the pubis, and helps form part of the obturator foramen. On the infero-posterior part of the ischium, there's a large, roughened area called the ischial tuberosity, which supports our weight while sitting, and where the inferior gemellus muscle and the hamstrings attach. At the junction of the body and ramus, there's a pointed projection called the ischial spine, where the sacrospinous ligament and superior gemellus muscle originate. Below the ischial spine, specifically between it and the ischial tuberosity, there's an arc called the lesser sciatic notch, and above the ischial spine is the greater sciatic notch, which is formed by parts of both the ischium and the ilium. Alright, now let's move on to the third and final part of the hip bone, the pubis. The pubis has three parts: a body, superior ramus, and inferior ramus. The body of the pubic bone is the thickest, most anterior part of the pubic bone. The superior ramus of the pubis connects to the ilium, forming the iliopubic ramus. The inferior pubic ramus connects to the inferior ramus of the ischium, forming the ischiopubic ramus. The angle at which both of these converge is called the pubic arch. Next is the pubic crest, which is a thickening on the anterior part of the pubis where the abdominal muscles attach. It has a swelling on its lateral side called the pubic tubercle, which is the distal attachment point of the inguinal ligament. The pectineal line, or pecten pubis, is an oblique ridge located on the lateral part of the superior pubic ramus, and it's where the pectineus muscle originates from. Anteriorly, the bodies of the right and left pubic bones are joined together in the median plane through a fibrocartilage called the interpubic disc. This connection forms a joint called the pubic symphysis. The pubic symphysis is a secondary cartilaginous joint that is supported superiorly by the superior pubic ligament, which connects the pubic bodies to the interpubic disc, and inferiorly by the inferior pubic ligament, which forms the apex of the pubic arch. When the bodies of the two pubic bones meet, they form an angle inferiorly called the subpubic angle. The pubic symphysis is important in stabilizing the pelvic girdle and transferring weight from the upper body to the lower body. And it undergoes important changes during childbirth to allow the fetus to pass through the birth canal. Now, looking at the hip bone from a lateral view, we can see a deep cup-shaped fossa called the acetabulum. This fossa is formed by the body of the ilium, the body of the ischium, and the superior ramus of the pubis. The head of the femur fits into this fossa, forming the hip joint. And right below the acetabulum, there's the obturator foramen. The obturator foramen is bound by the ramus of the ischium and the inferior ramus of the pubis, and it's partially covered by the obturator membrane. The small part of the obturator foramen that's not covered by the membrane is called the obturator canal, through which the obturator nerve and obturator blood vessels pass to supply structures in the medial compartment of the thigh. Also, the obturator membrane gives origin to two muscles, called the obturator internus and externus muscles. Now let's take a quick break. Pause the video and see if you can recall some of the most important features of the ilium, ischium, and pubis. Alright, now let's switch gears and talk about the sacrum. The sacrum is a wedge-shaped bone composed of 5 fused sacral vertebrae. The sacrum forms the posterior-superior wall of the pelvic cavity, and it has a superior base and an inferior apex. The base of the sacrum is formed by the superior surface of the S1 vertebra. Now, in its uppermost portion, the S1 vertebra has an anterior lip called the sacral promontory, which arches a bit towards the front. And on both sides, the sacral vertebrae extend laterally to form the sacral ale. The apex of the sacrum, its tapering inferior end, articulates inferiorly with the coccyx, forming the sacrococcygeal joint. This joint is a secondary cartilaginous joint, and is supported by the anterior and posterior sacrococcygeal ligaments. Alright, now the sacroiliac joints connect the sacrum to the hip bones, and they actually consist of 2 joints. An anterior synovial joint, which is formed by the articulation between the sacrum and the auricular surfaces of the ilium, and a posterior syndesmosis joint, formed by the articulation between the tuberosities found on the posterior surfaces of the ilium and the sacrum. The synovial portion is unlike other synovial joints as it has very limited mobility. But that's because their main role is to transmit the weight of the body into the hip bones. The sacroiliac joint is supported by multiple ligaments, including the anterior and posterior sacroiliac ligaments, which is synonymous with the fibrous synovial capsule, and they support the joint anteriorly and posteriorly. A third sacroiliac ligament, the interosseous sacroiliac ligament, is a primary structure involved in transferring weight and lies between the sacral and iliac tuberosities in the anterior synovial joint. There's also the sacrotuberous ligament, which goes from the posterior surface of the ilium and the lateral surfaces of the sacrum and the coccyx to the ischial tuberosity. And that's why it's called the sacro, referring to the sacrum, and tuberous, referring to the ischial tuberosity ligament. See? A lot of these ligaments are named based on their origin and insertion points, making them easier to remember. A similar ligament, called the sacrospinous ligament, passes from the lateral surface of the sacrum and the coccyx to the ischial spine. These two ligaments convert the greater and lesser sciatic notches into the greater and lesser sciatic foramina, as shown here. There are multiple important structures passing through these two foramina. For example, the sciatic nerve passes through the greater sciatic foramen to enter the posterior thigh. This nerve and its branches supply structures in the back of the thigh and the leg. Finally, the iliolumbar ligament binds the fifth lumbar vertebrae to the iliac crest of the ilium. The sacrotuberous, sacrospinous, and iliolumbar ligaments are called the vertebropelvic ligaments because they bind parts of the vertebral column to the hip bones. All right, I know that was a lot. Take a deep breath. And let's move on to the pelvis itself. The pelvis has a superior opening called the pelvic inlet and an inferior opening called the pelvic outlet. Both the sacrum and the hip bones participate in forming these openings. The bony edge defining the pelvic inlet is called the pelvic brim. Posteriorly, there's a sacral promontory and the ala of the sacrum. Laterally, there's a linea terminalis, which is composed of the arcuate line of the ilium and pecten pubis. Anteriorly, the pelvic brim is formed by the pubic symphysis. On the other hand, the pelvic outlet is bounded by the tip of the coccyx posteriorly, the inferior margin of the sacrotuberous ligament posterolaterally, and ischial tuberosities laterally, and the pubic arch anteriorly. Now the pelvic inlet divides the pelvic cavity into an upper, larger area called the greater or false pelvis, and a smaller, lower area called the lesser or true pelvis. Each part of the pelvis has its own boundaries. Let's start with the greater or false pelvis. The greater pelvis is superior to the pelvic inlet and defined by the ala of the ilium posterolaterally, and by the first sacral vertebra posteriorly. It contains the ilium and the sigmoid colon. The lesser pelvis is between the pelvic inlet and outlet, and is bounded by the hip bones, sacrum, and coccyx, and contains organs of the urinary and genital systems. Now, in anatomical position, the pelvis is tilted in the anterior-posterior plane in a way that makes the right and left anterior-superior iliac spines in the same plane as the pubic symphysis. This anterior pelvic tilt makes the pubic bones appear to be located inferiorly instead of anteriorly, making the pubic bones and pubic symphysis the main weight-bearing contributors. This also means the pelvic inlet is more vertical than horizontal. Also, this orientation of the pelvis makes the superior surface of the sacrum visible when looking at the pelvis from an anterior view. Furthermore, the acetabulum faces inferior laterally and articulates with the head of the femur, and the obturator foramen is inferior medial to the acetabulum. Finally, there are differences between male and female pelvises. These differences are mainly due to the heavier build and larger muscles of men compared with the female pelvis, which is adapted for childbirth. The male pelvis is thick and heavy compared to the female pelvis, which is thin and light. The lesser or true pelvis is narrow and deep in males, but wide and shallow in females. Also, in males, the pelvic inlet is heart-shaped, while in females it's oval-shaped. The pelvic outlet is comparatively small in males, but large in females, to give the fetus enough room to come out of the pelvis. Finally, there are differences between the male and female pelvis, which is below 70 degrees in males, but is more than 80 degrees in females. But these differences are not solely the interest of obstetrics and gynecology specialists. Other medical specialties, such as forensic medicine, use these facts to determine the gender of skeletal remains. However, remember that even though there are some differences between the male and female pelvis, the pelvis of any person may have some features of the opposite sex. Alright, as a quick recap, the pelvic girdle is composed of 3 bones, the 2 hip bones and the sacrum, and it connects the vertebral column to the lower limbs. Each hip bone is composed of 3 parts, the ilium, ischium, and pubis. Also, the 2 hip bones are connected posteriorly to the sacrum and anteriorly to each other through the pubic symphysis. The sacrum is connected to the ilia through the sacroiliac joints. These joints are supported by the sacrospinous and sacrotuberous ligaments, which help form the boundaries of the greater and lesser sciatic foramina. The pelvic cavity has a superior entrance called the pelvic inlet, and an inferior exit called the pelvic outlet. The pelvic inlet splits the pelvis into the greater and lesser pelvis. Now, in an anatomical position, the pelvic girdle is tilted in a way that brings the anterior superior iliac spine and the pubic symphysis line in the same plane. Finally, the male and female pelvises are different because males have a larger muscle mass, so their pelvis is thicker and heavier, while the female pelvis is adapted to childbirth, so it has a more spacious lesser pelvis and a larger pelvic outlet.
The pelvic cavity is a funnel-shaped space surrounded by pelvic bones, and it contains organs such as the urinary bladder, rectum, and pelvic genitals, to name a few. The pelvic cavity and the abdominal cavity together form the larger abdominopelvic cavity. The pelvic cavity is bounded superiorly by the pelvic inlet, which connects to the abdominal cavity, and inferiorly it's bounded by a group of muscles and the fascia surrounding them, called the pelvic floor or pelvic diaphragm, which is suspended above the pelvic outlet, with its central portion dipping below it. The pelvic cavity also has an antero-inferior wall, 2 lateral walls, and a posterior wall. So let's start with the antero-inferior wall, formed by the bodies and rami of pubic bones, and the pubic symphysis. Each pubic bone has 3 parts, a body, and a superior and inferior ramus. The body of the pubic bone is the thickest, most anterior part of the pubic bone. Anteriorly, the bodies of the right and left pubic bones are joined together in the median plane to form the pubic symphysis. Now, in an anatomical position, the pelvis is tilted in the anterior-posterior plane, making the pubic bones and pubic symphysis act more like a weight-bearing floor than an anterior wall. The lateral walls of the pelvic cavity are formed by the right and left hip bones. Each hip bone has an inferior opening called the obturator foramen, which is formed by the pubis and the ischium. The foramen is partially covered by a membrane called the obturator membrane. This membrane and the pelvic surfaces of the ilium and ischium give origin to a muscle called the obturator internus, which pads most of the lateral pelvic wall. Now, the fibers of the obturator internus muscle converge posteriorly to become tendinous, and then travel through a foramen called the lesser sciatic foramen. Finally, they attach to a large area on the lateral side of the femur called the greater trochanter. The medial surfaces of the obturator internus are covered by a fascia called the obturator fascia. This fascia covers most of the muscle and becomes thicker medially to form a tendinous arch. This arch gives origin to one of the muscles forming the pelvic floor or pelvic diaphragm. Additionally, the attachment of the pelvic diaphragm to the obturator fascia divides the obturator internus into a superior pelvic portion and an inferior perineal portion. Now let's move on to the posterior wall. The posterior wall has a bony and a musculoligamentous part. The bony part is formed by the sacrum and coccyx, which are the final parts of the vertebral column. The sacrum is a wedge-shaped bone composed of 5 fused sacral vertebrae. It forms the posterior-superior wall of the pelvic cavity and has a superior base and an inferior apex. Also, the sacrum connects to the hip bones on both sides, forming the sacroiliac joints. The anterior and posterior sacroiliac ligaments support this joint anteriorly and posteriorly. Next, there's the coccyx, also called the tailbone, which is a small triangular bone formed by the fusion of 4 vertebrae. Inferiorly, it attaches to the apex of the sacrum and forms the last part of the vertebral column. Ever wondered why it's called the tailbone? Well, that's because the coccyx is the remnant of a tail-like structure found in human embryos between weeks 4 and 8, called the caudal eminence. But it's not just an embryonic remnant. Multiple structures attach to the coccyx. These include parts of the gluteus maximus and coccygeus muscles, and a ligament called the anococcygeal ligament. Now, as the name suggests, the musculoligamentous part of the posterior wall is composed of muscles and ligaments. The piriformis is the main muscle which forms the posterolateral walls of the pelvic cavity. It originates from the superior part of the sacrum, goes through a foramen called the greater sciatic foramen, and finally attaches to the superior border of the greater trochanter of the femur. The ligaments that form the posterior wall are the anterior-sacroiliac, sacrotuberous, and sacrospinous ligaments. The anterior sacroiliac ligament is one of the ligaments that supports the sacroiliac joints anteriorly. The sacrotuberous ligament passes from the posterior surface of the ilium and the lateral surfaces of the sacrum and coccyx to the ischial tuberosity. Finally, the sacrospinous ligament passes from the lateral surface of the sacrum and the coccyx to the ischial spine. The pelvic floor, or pelvic diaphragm, is musculofascial, meaning that it is composed of a group of muscles and the fascia covering them, called the fascia of the pelvic floor. The pelvic floor separates the pelvic cavity superiorly from the perineum inferiorly, which is the space between the anus and the scrotum in males and between the anus and the vulva in females. The muscles that form the pelvic diaphragm are the coccygeus and the levator ani. The coccygeus are triangular muscles that run from the ischial spine to the lateral surfaces of the sacrum and coccyx. These muscles are innervated by branches of spinal nerves S4 and S5, and each coccygeus muscle flexes the coccyx anteriorly, helping it bear the body weight while sitting. Now, the levator ani muscle is the larger muscle forming the pelvic floor. Each levator ani originates anteriorly from the body of pubic bones and to the ischial spines posteriorly. Between these two bony origins, each levator ani muscle attaches to the tendinous arch of the levator ani, which is a medial thickening of the obturator fascia called the tendinous arch of the levator ani. The pelvic diaphragm spans between the anterior, lateral, and posterior walls of the pelvis, closing most of the pelvic girdle ring, but it leaves a small gap anteriorly just behind the pubic bones called the urogenital hiatus. In females, the vagina passes through this gap, as well as the urethra in both females and males. The levator ani forms the dynamic floor that supports the abdominopelvic viscera. And most of the time, it's contracted to assist in maintaining urinary and fecal continence. So basically, it helps us hold it in until we can get to the bathroom, or a bush where no one's looking. It also contracts during forced expiration, sneezing, coughing, and vomiting to increase viscera support during times of increased intra-abdominal pressure. And finally, it relaxes in order to allow urination or defecation. Alright, now the levator ani muscle consists of 3 parts: puborectalis, pubococcygeal, and iliococcygeal. All three are innervated by the nerve to levator ani coming from branches of S4, the inferior anal nerve, and coccygeal plexus. The puborectalis is the thicker, narrower, medial part of the levator ani, and it bounds the urogenital hiatus from both sides. And its name kind of gives away the whole story. Pubo means that this part attaches to the posterior surfaces of the bodies of the pubic bones anteriorly, and rectalis means that this part forms a sling around the ano-rectal junction. Easy, right? The puborectalis is U-shaped, with the tips of the U attached anteriorly to the posterior surfaces of the bodies of both pubic bones. The bowl of the U forms a puborectal sling around the junction between the rectum and the anus, called the ano-rectal junction or flexure. So, when all is said and done, the puborectalis plays a major role in maintaining fecal continence. Next, there's the pubococcygeus, which is the wider, thinner, intermediate part of the levator ani muscle. This part arises lateral to the puborectalis, from the posterior surfaces of the bodies of pubic bones, in addition to the anterior tendinous arch. The lateral muscle fibers go posteriorly to attach to the coccyx, hence its name, pubococcygeus. The medial muscle fibers of the paired pubococcygeus muscles fuse in midline to form a median tendinous raphe, which forms part of the anococcygeal body, or ligament between the anus and coccyx, often referred to as the levator plate. This raphe unites with the external anal sphincter, forming a ligament that extends between the coccyx and the anus, called the anococcygeal body, or ligament. The main action of the pubococcygeus muscle is to maintain urinary continence and help in male ejaculation. Finally, there's the iliococcygeus, which is the posterolateral part of the levator ani. This part arises from the ischial spines and tendinous arch, and inserts on the coccyx and anococcygeal body. It is usually thin and poorly developed, and it usually looks like a fibrous tissue rather than muscle fibers. Alright, as a quick recap. The pelvic cavity is a funnel-shaped cavity bounded superiorly by the pelvic inlet and inferiorly by the pelvic floor or diaphragm. It has an antero-inferior wall, 2 lateral walls, and a posterior wall. The antero-inferior wall is formed by the bodies and rami of pubic bones. The lateral wall is formed by the obturator membrane and the obturator internus muscle. Finally, the posterior wall is formed by the sacrum and coccyx, and the anterior sacroiliac, sacrotuberous, and sacrospinous ligaments. The pelvic floor contains 2 muscles, the coccygeus and the levator ani. Those muscles support the pelvic viscera and help in maintaining fecal and urinary continence.
The small intestine is a part of the digestive tract specialized in absorbing nutrients and minerals from the food we eat. It's located in the abdominopelvic cavity, and it begins at the pylorus of the stomach, and it ends at the ileocecal junction, where it continues with the large intestine. It has 3 major components: the duodenum, which can be divided into 4 parts, the jejunum, and the ileum. Now, when talking about structures of the abdomen, we often encounter the terms retroperitoneal or intraperitoneal. Retroperitoneal is a description for abdominal structures that are only partially covered by peritoneum and lie posterior or behind the abdominal peritoneum, where intraperitoneal means that these structures have invaginated and are completely covered by the visceral peritoneum. So, of these components, the proximal portion of the first part of the duodenum, in addition to the jejunum and ileum, are intraperitoneal, where the distal portion of the first part of the duodenum, in addition to the second, third, and fourth parts of the duodenum, are retroperitoneal, and are found posteriorly in the retroperitoneal cavity. That being said, let's have a closer look at the duodenum and its 4 parts. Overall, the duodenum is shaped like the letter C, curving around the head of the pancreas, and consists of the first or superior part, second or descending part, third or inferior part, and fourth or ascending part. The first part lies in the transverse plane and begins anterolaterally to the right of the L1 vertebral body, continuing to the pylorus. The proximal portion of the first part has a segment of the lesser omentum called the hepatoduodenal ligament attached to its superior surface, and the greater omentum attached to the inferior surface. The proximal 2 centimeters of the first part is also more dilated and freely mobile, as it is intraperitoneal with its anterior and posterior surface covered in peritoneum, and is referred to as the ampulla or the duodenal cap. This is in contrast to the distal 3 centimeters, which is retroperitoneal and therefore not mobile. The first part of the duodenum travels laterally to the right and has the liver and gallbladder overlying it, and it has the IVC, bile duct, and gastroduodenal artery posterior. The second part, or descending part of the duodenum, is completely retroperitoneal. It curves downward around the head of the pancreas, which is medial, and runs inferiorly from the L1 to the L3 vertebra, to the right of and parallel to the IVC. Overlying the second part is the transverse colon and the convolutions of the small intestine. Where posterior to it, there's the hilum of the right kidney, its vessels, and ureter. If we open up the second part of the duodenum and look inside, we can see the major duodenal papilla on its posteromedial wall. That's where the main pancreatic duct combines with the common bile duct to form a hepatopancreatic ampulla, which carries the pancreatic juices and bile to the duodenum. Of note, these can also be referred to as the papilla of Vater and ampulla of Vater respectively, not to be confused with the popular Darth Vader. Sometimes, above the major duodenal papilla, there is also a minor duodenal papilla where the accessory pancreatic duct opens. The duodenum then turns to the left, and the third part starts at the level of L3. This part is also completely retroperitoneal. The third part of the duodenum passes horizontally to the left below the head of the pancreas. Posterior to it are the inferior vena cava, or IVC, the aorta, the proximal parts of the inferior mesenteric vessels, and the body of the L3 vertebra. Anterior to the inferior part, there are the superior mesenteric artery, or SMA, the superior mesenteric vein, or SMV, and parts of the jejunum. Finally, the duodenum turns upwards and becomes its fourth part, called the ascending part, which ascends to the left of the L3 vertebra and aorta, up to the L2 vertebral level and the inferior border of the pancreas. Medial to the fourth part, there are the SMA, SMV, and uncinate process of the pancreas. Then it turns anteriorly to connect with the jejunum, forming the duodenojejunal flexure, or junction, at the level of L2. This site hangs by the suspensory muscle of the duodenum, also known as the ligament of Treitz, that is made out of the skeletal muscles from the diaphragm and the smooth muscles of the duodenum. Now, the duodenum mainly gets arterial blood from the celiac trunk and the SMA. The celiac trunk gives off the common hepatic artery, which also gives rise to the supraduodenal artery supplying portions of the first and second duodenal parts, and the gastroduodenal artery, which has a branch called the superior pancreaticoduodenal artery that supplies the first two parts of the duodenum up until the major duodenal papilla. The SMA, on the other hand, gives off a branch called the inferior pancreaticoduodenal artery, which supplies the other two parts of the duodenum distal to the major duodenal papilla. The superior and inferior pancreaticoduodenal arteries give anterior and posterior branches that connect with each other, forming anastomoses between the celiac trunk and the SMA. The veins of the duodenum drain alongside the arteries, and venous blood is collected by the splenic and superior mesenteric vein, which eventually drain into the hepatic portal vein. The lymphatic vessels of the duodenum accompany arteries as well, and drain via the pancreaticoduodenal lymph nodes located along the superior and inferior pancreaticoduodenal arteries to the pyloric lymph nodes along the gastroduodenal artery and the superior mesenteric lymph nodes along the SMA. All of these ultimately drain into the celiac lymph nodes. As for the innervation of the duodenum, the sympathetic fibers derive from the greater thoracic splanchnic nerves arising from T5 to T9, the lesser thoracic splanchnic nerves from T10 to T11, while the parasympathetic fibers derive from the vagus nerves. Together, these fibers of both the SNS and PNS go to the celiac and superior mesenteric plexuses that surround the roots of these arteries. Here, the sympathetic fibers synapse in prevertebral ganglia such as the celiac and superior mesenteric ganglion and send their postsynaptic sympathetic fibers through the periarterial plexuses following the pancreatico-duodenal arteries. The parasympathetic fibers, on the other hand, just pass through the celiac and superior mesenteric plexuses, as well as the periarterial plexuses, and eventually synapse in the intrinsic ganglia found in the walls of the duodenum, giving short, postsynaptic parasympathetic fibers to their destination. Both of these nerve pathways eventually send their postsynaptic fibers to innervate the duodenum. Before we move on, let's take a break and see if you can identify the arterial blood supply of the duodenum. Now, after the duodenum, we have the jejunum, which is the second part of the small intestine, beginning at the duodenojejunal flexure, where the small intestine becomes intraperitoneal again. And after the jejunum, there's the ileum, which is the third and final part of the small intestine. There is no clear visible demarcation between the jejunum and ileum, but when we divide the abdominopelvic cavity into 4 quadrants, we can see that the jejunum is mainly situated in the left upper quadrant, while the ileum is mostly in the right lower quadrant. Together, the jejunum and ileum are about 7 meters long, with the jejunum taking the first 2/5 and the ileum the last 3/5 of the length. On the right side of the pelvic cavity, the ileum terminates into the medial side of the cecum at the iliocecal junction. Now, since they are intraperitoneal, both the jejunum and ileum are covered by visceral peritoneum. Where the visceral peritoneum reflects off the walls of the intestine, it creates a double fold of peritoneum called the mesentery, which attaches the jejunum and ileum to the posterior abdominal wall. The root of the mesentery extends from the duodenojejunal flexure on the left side of the L2 vertebra across the ascending and inferior parts of the duodenum, aorta, and IVC, all the way to the iliocecal junction and the right sacroiliac joint. Between the folds of the mesentery, there are the superior mesenteric vessels, lymphatic vessels, and nerves that supply the small intestine, as well as fat tissue. The arterial blood supply for the jejunum and ileum is provided by the SMA, which travels within the mesentery, giving off around 15 to 18 jejunal and ileal artery branches. On their way toward the intestines, these branches connect with each other and form loops called the arterial arcades, which give rise to many straight arteries known as the vasa recta. And here's where the difference between the jejunum and ileum comes in. The jejunum has fewer arcades with larger loops and longer vasa recta, while the ileum has more arcades with shorter loops and shorter vasa recta. Lymphatic drainage of the jejunum and ileum start in specialized lymphatic vessels in the intestinal villi called lacteals. These empty into lymphatic plexuses in the walls of the jejunum and ileum, which drain into a variety of lymphatic vessels and nodes found in the layers of mesentery. Eventually, all these collect into the superior mesenteric lymph nodes. Furthermore, lymph from the terminal ileum drains into the ileocolic lymph nodes. As for the innervation of the jejunum and ileum, the sympathetic fibers derive mainly from the T8 to T10 portions of the greater and lesser thoracic splanchnic nerves, while the parasympathetic fibers derive from vagus nerves. Just like for the duodenum, they all go to the celiac and superior mesenteric plexuses, where sympathetic fibers synapse in the celiac and superior mesenteric ganglia and pass through the periarterial plexuses, and parasympathetic pass through all these plexuses to synapse in the intrinsic ganglia in the intestinal wall, where both pathways eventually continue on to innervate the jejunum and ileum. Remember, sympathetic innervation reduces peristaltic and secretory activity to stop digestion, where parasympathetic increases peristaltic and secretory activity, facilitating digestion. Also, don't forget about sensory information. Visceral afferent fibers conveying pain travel with the sympathetic fibers, and visceral afferent fibers conveying reflex sensations travel with the parasympathetic fibers. Let's take another quick break and see if you can identify the jejunum and ileum, as well as their blood supply. Alright, as a quick recap, the small intestine has three major parts: the duodenum, jejunum, and ileum. The duodenum has four parts. Most of the duodenum is retroperitoneal except for the proximal portion of the first part. The duodenum continues with the jejunum at the duodenojejunal junction, which is suspended by the ligament of Treitz. The jejunum and ileum are intraperitoneal structures, where the jejunum is mostly situated in the upper left quadrant and ileum in the lower right quadrant. Another difference is that the jejunum has longer vasa recta and fewer arcades with larger loops, while the ileum has shorter vasa recta and more arcades with shorter loops. The ileum continues with the large intestine at the ileocecal junction. The small intestine is supplied from the celiac trunk and the SMA via the superior and inferior pancreatico-duodenal arteries and jejunal and ileal arteries respectively. Lymphatic drainage follows the nodes of the arteries supplying the small intestine, which eventually go on to drain into the superior mesenteric and celiac nodes. Sympathetic innervation comes from the greater and lesser splanchnic nerves, while the parasympathetic fibers derive from the vagus nerves. Visceral afferents for pain travel with sympathetic nerves, and reflex sensation with parasympathetic nerves. There are numerous vessels and nerves that course throughout the bony and muscular architecture of the thoracic wall, and they provide innervation and blood supply to the structures within and around the thoracic cage. First, let's have a look at the contents of the intercostal space, specifically the neurovascular bundle containing the intercostal nerve, artery, and vein. It is important to remember the order of these structures, with the most superior structure being the intercostal vein, and below it comes the artery, and below the artery, the nerve. To easily remember this, think VAN, or think about a van that's blue at the top, red in the middle, and yellow in the inferior part. The inferior portion of the ribs also have a costal groove, which only provides partial protection for these structures, so they can be damaged during penetrating intercostal injuries or any intervention that requires intercostal access. Now, let's talk about the nerves. There are 12 pairs of thoracic spinal nerves which supply the thoracic wall. They leave the intervertebral foramina as soon as they are formed, dividing into anterior and posterior rami. Now, the anterior rami of nerves T1 through T11 form the intercostal nerves that run along the intercostal spaces along the inferior borders of the ribs, with the third intercostal nerve traveling between the third and fourth ribs. The anterior ramus of nerve T12 that courses inferior to the 12th rib is the subcostal nerve. The intercostal nerves give anterior and lateral cutaneous branches to innervate the thorax and abdominal wall, muscular branches to supply the muscles of the thoracic wall, and they give rami communicantes or communicating branches that connect the intercostal nerves to a sympathetic trunk on the same side. The posterior rami of thoracic spinal nerves pass posteriorly, lateral to the articular processes of the vertebrae in order to supply the joints, deep back muscles, and skin of the posterior thoracic region. Now, the intercostal nerves are either typical or atypical, and the typical ones are the third through the sixth pair. These nerves enter the medial-most parts of the posterior intercostal spaces. Initially, they run with the endothoracic fascia just between the parietal pleura and the internal intercostal membrane. Near the angles of the ribs, these nerves pass between the internal intercostal and the innermost intercostal muscles. From here, they continue to course in or inferior to the costal grooves, running inferior to the intercostal arteries. Keep in mind that the arteries run inferior to the intercostal veins. Near the angles of the ribs, collateral branches arise and run along the superior border of the rib below. The nerves continue anteriorly between the internal and innermost intercostals and supply these muscles and other muscles, and also give rise to the lateral cutaneous branches in the mid-axillary line. Anteriorly, the nerves appear on the internal surface of the internal intercostal muscle. Near the sternum, these nerves turn anteriorly and pass between the costal cartilages to become anterior cutaneous branches. Atypical intercostals are the first two intercostal nerves which run on the internal surface of the first and second ribs, not along the inferior margin in the costal groove, and the 7th through 11th nerves which eventually become thoracoabdominal nerves of the anterior abdominal wall. Most thoracic spinal nerves, specifically T2 through T12, give rise to the dermatomal map of the trunk through their posterior ramus and the lateral and anterior cutaneous branches of its anterior ramus. This dermatomal map extends from the posterior median line to the anterior median line, and it represents the area of skin supplied by the spinal nerves. Exact dermatomal distributions may vary depending on the source, however they are generally agreed upon with certain dermatomes acting as key landmarks. For example, dermatome T4 includes the nipple and T10 includes the umbilicus. Almost there. Let's see if you can identify the typical intercostal nerves in this picture. Alright, finally, let's look at the arterial supply to the thoracic wall, which comes from the posterior intercostal and subcostal arteries arising from the thoracic aorta, the internal thoracic or mammary artery coming from the subclavian artery, and the supreme or superior intercostal artery arising from the costocervical trunk of the subclavian artery, and the superior and lateral thoracic arteries from the axillary artery. With the exception of intercostal space 10 and 11, each intercostal space is supplied by a large posterior intercostal artery and a small pair of anterior intercostal arteries. The posterior intercostal arteries of the first and second intercostal spaces arise from the supreme or superior intercostal artery, which is a branch of the costocervical trunk of the subclavian artery. The posterior intercostal arteries of the 3rd through the 11th intercostal spaces arise posteriorly from the thoracic aorta. All posterior intercostal arteries give rise to a dorsal branch that accompanies the posterior ramus of the spinal nerve to supply the spinal cord, vertebral column, back muscles, and skin. They also give rise to a small collateral branch that crosses the intercostal space and runs along the superior border of the rib below. The posterior intercostal arteries accompany the intercostal nerves through the intercostal spaces. Close to the angle of the rib, the arteries enter the costal grooves, where they lie between the intercostal vein and nerve. At first, the arteries run in the endothoracic fascia between the parietal pleura and the internal intercostal membrane, and then they run between the innermost intercostal and internal intercostal muscles. They have terminal and collateral branches that anastomose anteriorly with anterior intercostal arteries. Now, the ipsilateral pairs of anterior intercostal arteries supply the anterior parts of the upper 9 intercostal spaces. They pass laterally in the intercostal space, one near the inferior margin of the superior rib and the other near the superior margin of the inferior rib. In the first 2 intercostal spaces, they lie initially in the endothoracic fascia between the parietal pleura and the internal intercostal muscles. They supply the intercostal muscles and send branches through them to supply the pectoral muscles, breast, and skin. They're missing from the inferior 2 intercostal spaces because these spaces are supplied only by the posterior intercostal arteries and their collateral branches. Then there are the internal thoracic arteries, previously called the internal mammary arteries, arise in the root of the neck from the inferior surfaces of the first parts of the subclavian arteries. Then they descend into the thorax posterior to the clavicle and first costal cartilage. Then they descend on the internal surface of the thorax lateral to the sternum and posterior to the upper 6 costal cartilages and internal intercostal muscles. After going down past the second costal cartilage, the internal thoracic arteries run anterior to the transversus thoracis muscle. They terminate in the 6th intercostal space by dividing into the superior epigastric and the musculophrenic arteries. They also directly give rise to the anterior intercostal arteries that supply the superior 6 intercostal spaces. There is also the subcostal artery, which is a branch of the thoracic aorta. It courses along the inferior border of the 12th rib and provides blood supply to muscles of the anterolateral abdominal wall. Last but not least, let's have a quick look at the veins of the thoracic wall. The intercostal veins accompany the intercostal arteries and nerves and lie most superior in the costal grooves. There are 11 posterior intercostal veins and 1 subcostal vein on each side. The posterior intercostal veins anastomose with the anterior intercostal veins, which are tributaries of the internal thoracic veins. As they get close to the vertebral column, the posterior intercostal veins receive a posterior branch, which accompanies the posterior ramus of the spinal nerve of that level, and an intervertebral vein that drains the vertebral venous plexuses of the vertebral column. Now, most posterior intercostal veins, specifically those who drain the 4th through the 11th intercostal space, end in the azygous or hemiazygous vein system. The azygous system conveys venous blood to the superior vena cava. The posterior intercostal veins of the first intercostal space enter directly into the right and left brachiocephalic vein. The posterior intercostal veins of the second and third and sometimes fourth intercostal spaces join to form a trunk called the superior intercostal vein. The right superior intercostal vein is usually the final tributary of the azygous vein before it enters the superior vena cava. The left superior intercostal vein usually empties into the left brachiocephalic vein. The internal thoracic veins are the companion veins of the internal thoracic arteries. And one last quiz before the recap. Can you label the arteries in this picture? Alright, as a quick recap, the contents of the intercostal space can be easily remembered as van, meaning the most superior is the intercostal vein, below it comes the artery, and below the artery, the nerve. There are 12 pairs of thoracic spinal nerves that divide into a posterior rami as well as anterior rami that continues as the intercostal nerve. The typical intercostal nerves are the 3rd through the 6th intercostal nerves. Through the posterior ramus and the lateral and anterior cutaneous branches of the anterior ramus, the cutaneous branches of the T2 through T12 thoracic spinal nerves supply the dermatomes of the trunk that extends from the posterior median line to the anterior median line. The arterial supply to the thoracic wall comes from the posterior intercostal and subcostal arteries arising from the thoracic aorta, the internal thoracic and superior intercostal artery, and the superior and lateral thoracic arteries from the axillary artery. The veins of the thoracic wall are the intercostal veins that accompany the intercostal arteries and nerves, and they mostly drain into the azygous system. The posterior intercostal veins of the first intercostal space enter directly into the right and left brachiocephalic vein. The posterior intercostal veins of the second and third and sometimes fourth intercostal spaces join to form a trunk called the superior intercostal vein.
The thoracic wall surrounds the thoracic cavity, which is the anatomical region where viscera, like the heart and lungs, can be found. The thoracic wall contains a variety of muscles, where many of the muscles that cover and attach to the thoracic wall have a primary action elsewhere, such as the arms, neck, and abdomen, and it's their secondary actions that affect the movements of the thoracic wall. For example, the pectoralis major and pectoralis minor muscles overlay the thoracic wall, but they are primarily involved with movements of the upper limb, and their secondary action is to act on the thoracic wall as accessory muscles of respiration. However, the thoracic wall also does have muscles that have their primary action in the thoracic wall, and these are called the true muscles. They are the serratus posterior, levatorius costarum, subcostals, transversus thoracis, and the innermost internal and external intercostals. Let's start with the two serratus posterior muscles. There's a serratus posterior superior muscle and serratus posterior inferior muscle on each side. The serratus posterior superior muscles have their proximal attachment at the nuchal ligament and the spinous processes of C7 through T3 vertebrae, and their distal attachment at the superior borders of the 2nd through 5th ribs. Its main action is the elevation of the superior 4 ribs during inspiration. The serratus posterior inferior muscles have their proximal attachment at the spinous processes of T11 through L2 vertebrae and their distal attachment at the inferior borders of 9th through 12th ribs near their angles. Its main action is depressing the inferior ribs in order to prevent them from being pulled upwards by the diaphragm. Both of these muscles have been shown to have a role in proprioception, meaning that they might make you aware of the position of the body. For example, when you're lying in bed with your eyes closed, these muscles, among others, could send signals to the brain regarding where you are and what's your position in relation to the bed. Next, the levatorius costarum muscles are 12 triangle-shaped muscles with a proximal attachment to the transverse processes of C7 through T11 vertebrae and distal attachments to subadjacent ribs between the tubercle and the angle of that rib. Their main action is to elevate the ribs. Then there are the intercostal muscles, which are a group of muscles that occupy the space between the ribs. The external intercostal muscles form the superficial layer, while the internal intercostal muscles form the inner layer. Now, the innermost intercostal muscles are fibers of the internal intercostal muscles that are the deepest fiber layer and lie internal to the intercostal nerve and vessels. All 3 intercostal muscles have the same origin and insertion. So their proximal attachment is at the inferior border of the ribs above and their distal attachment at the superior border of the rib below. For example, the intercostals at the 3rd intercostal space all attach to the inferior border of the 3rd rib and the superior border of the 4th rib and so on. In addition, they are all innervated by the intercostal nerves traveling in their respective intercostal spaces. The main differences between the intercostals are their fiber orientation and how far they span anteriorly to posteriorly. So let's look at the 11 pairs of external intercostal muscles that occupy the intercostal spaces from the tubercles of the rib posteriorly to the costochondral junctions anteriorly, where the most anterior muscle fibers are actually replaced by fascia called the external intercostal membranes. These muscles run infro-anteriorly from the rib above to the rib below. To visualize this, the fibers run in the same way the fingers of your hand would if you placed your hands in the pockets of your jeans. The lower external intercostals are continuous anteriorly with the external oblique muscles in the abdominal wall. The external intercostal muscles elevate the ribs during forced inspiration. Then there are the 11 pairs of internal intercostal muscles, which run deep to and at right angles to the external intercostals. This means that their muscle fibers run infero-posteriorly from their origin compared to infro-anteriorly like the external intercostals. To visualize this, the fibers run in the same way your fingers would if you were to cross your arms to hug yourself and place your hands on your hips. The internal intercostal attaches to the bodies of the ribs and their costal cartilages all the way to the sternum anteriorly and posteriorly as far as the angles of the ribs. Between the ribs and medial to the angles, the internal intercostal muscles are replaced by fascia called the internal intercostal membranes. The inferior internal intercostal muscles are continuous with the internal oblique muscles in the anterior abdominal wall. The internal intercostal muscles mostly play a role during expiration. Finally, the innermost intercostal muscles are basically the deeper parts of the internal intercostal muscles, and are separated from them by intercostal nerves and vessels. These muscles pass between the internal surfaces of adjacent ribs and occupy the most lateral parts of the intercostal spaces. And just like the internal intercostal muscles, they likely play a role during expiration. Now, take a moment and try and identify some of the structures we have just talked about on these images. Now, let's have a quick look at the anatomy and physiology of breathing. The diaphragm is the main muscle in inspiration, while expiration is usually passive, except when a person is trying to exhale against resistance, like when blowing air into a balloon, or when one's trying to expel air more rapidly, like when coughing or sneezing. Both external and internal intercostals are active during respiration, but their action is mostly isometric, meaning their contraction does not actually cause movement of the thoracic cage. This isometric contraction is to support the intercostal space, especially during inspiration when internal thoracic pressures are lowest. However, during forced respiration, these muscles become more active and will produce movement of the ribs. Let's take a look at this image. Now, take a really deep breath, literally, do it, and see what happens. When undergoing forced inspiration, the external intercostals and part of the internal intercostals called the interchondral portion contract and rotate the ribs superiorly at their posterior axes. The result is the elevation of the ribs and an increase of the anteroposterior diameter. This occurs because the ribs are hinged posteriorly by a fixed vertebral column and anteriorly by a movable sternum. During forced expiration, the interosseous part of the internal intercostal muscles contract and rotate the ribs inferiorly at their posterior axes. The result is the depression of the ribs and sternum and the decrease in the anteroposterior diameter. So, this is to say that the interosseous and the interchondral parts of the internal intercostal muscles have two different actions during forced respiration, even though these muscle fibers have the same orientation. This all occurs because as the ribs move postero-anteriorly, they descend as they run towards the sternum. Their lowest point is approximately at the junction with the costal cartilage, and then ascending toward the sternum. The interchondral fibers of the internal intercostals are medial to this point. Therefore, their fibers are parallel to the slope of the ribs, and their contraction causes the hinged ribs to rotate superiorly based on their biomechanical pull. The interosseous part of the internal intercostal is lateral to this low point, causing its fibers to be perpendicular to the slope of the rib, and contraction of these fibers rotates the ribs inferiorly, pulling them down. Other muscles in the thoracic wall include the subcostal muscles. They are usually well developed only in the lower thoracic wall, and they vary in size and shape. Proximally, they attach to the internal surface of lower ribs near their angles, and distally, they attach at the superior border of the second or third ribs below. This means that these muscles actually cross one or two intercostal spaces. The subcostal muscles run in the same direction as the internal intercostals, and are thought to act in the same way as the internal intercostals. Now, the transversus thoracis muscles have their proximal attachment at the posterior surface of the lower sternum and their distal attachment at the internal surface of the costal cartilages 2 through 6. They are continuous with the transversus abdominis muscles in the anterolateral abdominal wall. They may slightly depress the ribs during expiration and might provide proprioceptive information. Both of these muscles are innervated by the intercostal nerves. Finally, let's move on to the endothoracic fascia, which is a thin layer that lies between the internal aspect of the thoracic cage and the lining of the pulmonary cavities, and attaches the deeper situated costal parietal pleura to the thoracic wall. The endothoracic fascia continues over the apices of the lungs, where it becomes more fibrous and is called the suprapleural membrane. Alright, as a quick recap. The true muscles of the thoracic wall are serratus posterior, levator's costarum, subcostals, transversus thoracis, and the intercostals. The role of the intercostal muscles in respiration is to support the intercostal space, especially during inspiration when the internal thoracic pressures are the lowest. During forced inspiration, the external intercostals and the interchondral portion of the internal intercostal muscles contract and rotate the ribs superiorly at their posterior axes, elevating the ribs. During forced expiration, the interosseous part of the internal intercostal muscles contract and rotate the ribs inferiorly at their posterior axes, depressing the ribs. The endothoracic fascia is a thin layer that lies between the internal aspect of the thoracic cage and the lining of the pulmonary cavities.
The thorax is the area between the neck and abdomen and consists of the thoracic cavity, its contents, and the walls that surround it. The thoracic skeleton forms the osteocartilaginous thoracic cage that protects the thoracic viscera and some of the abdominal organs. The skeleton is made up of the sternum, 12 pairs of ribs and associated costal cartilages, as well as 12 thoracic vertebrae and intervertebral discs interposed between them. The ribs and costal cartilages form the largest part of the thoracic cage, and both can be identified numerically, going from 1 to 12 for the ribs, and going from 1 to 10 for the costal cartilage, as ribs 11 and 12 do not have an associated costal cartilage. Now, the true thoracic wall includes the thoracic cage and the muscles between the ribs and the skin, as well as subcutaneous tissue, muscles, and fascia that cover its anterolateral aspect. The structures that cover its posterior aspect are considered to belong to the back. Additionally, the mammary glands of the breasts lie within the thoracic wall subcutaneous tissue, and the anterolateral axio-appendicular muscles are also considered part of the thoracic wall. Okay, let's start talking about the ribs, which form most of the thoracic cage. They're curved, flat, lightweight, and highly resilient bones. Each rib has a spongy interior that contains bone marrow or hematopoietic tissue, which forms blood cells. There are 3 types of ribs based on their connection to the sternum: true, false, and floating ribs. The true, or vertebrosternal ribs, are the first 7 pairs of ribs, and they attach directly to the sternum through their own costal cartilages. The false, or vertebrochondral ribs, are the 8th, 9th, and usually the 10th pair of ribs, and their cartilages are connected to the cartilage of the rib above them. Consequently, their connection to the sternum is indirect. The floating ribs, or vertebral or free ribs, are the 11th, the 12th pair of ribs, and sometimes the 10th pair of ribs. The cartilages of these ribs don't connect anteriorly to the sternum at all. Instead, they end up in the posterior abdominal musculature. Ribs can further be classified as either typical or atypical ribs. Typical ribs are the 3rd through the 9th pair of ribs and have the following components: head, neck, tubercle, and body. On the posterior view, the head of a typical rib is wedge-shaped and has 2 facets, superior and inferior, that are separated by the crest of the head. The inferior facet articulates with the numerically corresponding vertebra, and the superior facet articulates with the vertebra above it. The neck connects the head with the body at the level of the tubercle. The tubercle, located at the junction of the neck and body, has a smooth articular part that connects with the corresponding transverse process of the vertebra, and a rough non-articular part where the costotransverse ligament attaches. The body is thin, flat, and curved, especially at the costal angle, where the rib makes an anterolateral turn. This angle also demarcates the lateral limit of attachment of the deep back muscles to the ribs. The internal surface of the body is concave and has a costal groove that's parallel to the interior border of the rib, which provides protection for the intercostal nerves and vessels at that level. Now the first, second, 10th through 12th rib are atypical because they are unlike the typical ribs in various ways. So the first rib is the broadest, shortest, and most sharply curved of the 7 true ribs. Its body is the widest and is nearly horizontal. Its head has a single facet because it only articulates with the T1 vertebra, and its body has 2 transverse grooves crossing its superior surface for the subclavian artery and vein. The grooves are separated by a scalene tubercle and ridge to which the anterior scalene muscle is attached. It also has a tubercle which articulates with the transverse process of T1. Now the second rib has a thinner and less curved body, and it's longer than the first rib. Its main atypical feature is a rough area on its upper surface called the tuberosity for serratus anterior, where the serratus anterior originates. Its head has 2 facets for articulation with the bodies of T1 and T2 vertebrae. The 10 through 12th ribs, like the first rib, only have 1 facet on their heads and articulate with a single vertebra. The 11th and 12th ribs are short and don't have a neck or tubercle. Now the head of each rib articulates with thoracic vertebrae via costovertebral joints, which are synovial plane joints. Regarding ribs 2 through 9, the head of each rib articulates with the superior costal facet of the vertebral body of the same number and with the inferior costal facet of the vertebral body above it and to the intervertebral disc between them. So, for example, the head of rib 4 articulates with the superior costal facet of the vertebral body of T4 and with the inferior costal facet of the vertebral body of T3 and with the intervertebral disc between those 2 vertebrae. Unlike ribs 2 through 9, the 1st, 11th, 12th, and sometimes the 10th rib only articulate with a single vertebral body at the same vertebral level as the rib. For example, rib 11 articulates with T11. Then there are the costa transverse joints, which are also synovial plane joints. Regarding ribs 1 through 10, the tubercle of the rib articulates with the transverse process of the vertebra of the same number. Ribs 11 and 12 don't articulate with the transverse process of vertebrae of the same number. Now let's take a deep breath and play a fun game. Let's see if you can identify which atypical rib we're showing in these images and what the structures are that form a typical rib. Moving on to the sternum, which is a flat, elongated bone that forms the middle of the anterior part of the thoracic cage. The sternum is the protector of the mediastinal viscera, especially the heart. It consists of 3 parts: manubrium, body, and xiphoid process. Let's now identify each structure and their components one by one in both anterior and lateral views. The manubrium is a trapezoidal bone and is the widest and thickest part of the sternum. The jugular notch, or the suprasternal notch, is the superior and concave border of the manubrium and can be easily palpated. The notch is deepened by the medial ends of the clavicles, which are much larger than the small clavicular notches in the manubrium found laterally on either side. Now, the sternoclavicular joint is a saddle type of synovial joint, and the joints form between the ends of the clavicles and the clavicular notches of the manubrium, as well as the first costal cartilages. Inferior and lateral to the clavicular notch, there's the first sternocostal joint, which is the costal cartilage of the first rib attached to the lateral border of the manubrium of the sternum, which is classified as a primary cartilaginous joint. Between the manubrium and body of the sternum, there's the manubriosternal joint, which is a secondary cartilaginous joint. Now, the manubrium and body of the sternum lie in different planes superior and inferior to their junction. Because of this, their junction forms an angle called the angle of Louis or the sternal angle, which you can see better in a lateral view. The sternal angle is palpable and even visible in young individuals. The sternal angle lies at the level of T4, T5 intervertebral disc and the space between the third and fourth thoracic spinous processes. The sternal angle also marks the level of the second pair of costal cartilages. Now, the left side of the manubrium is anterior to the arch of the aorta, and its right side overlies the merging of the brachiocephalic veins to form the superior vena cava. The superior vena cava then passes inferiorly deep to the manubrium and manubriosternal joint, but it projects as much as a finger breadth to the right margin of the manubrium. The body of the sternum is longer, narrower, and thinner than the manubrium, and is located roughly at the level of T5 through T9 vertebrae. Particularly, its width varies due to the scalloping of the lateral borders of the costal notches. Finally, the body of the sternum articulates with the costal cartilages of ribs 2 through 7 through synovial plane joints to form the rest of the sternocostal joints. The xiphoid process is the smallest and most variable part of the sternum. It's thin and elongated, and its end lies at the level of T10 vertebrae. Between the body of the sternum and the xiphoid process, there's the xiphosternal joint, which is a primary cartilaginous joint. The xiphoid process is important because the xiphosternal joint indicates the inferior limit of the central part of the thoracic cavity projected onto the anterior body wall. This joint is also the site of the infrasternal angle or subcostal angle formed by the left and right costal margins. It's also a midline marker for the superior limit of the liver, the central tendon of the diaphragm, and the inferior border of the heart. Now let's look at the big picture. So there are 11 intercostal spaces that separate the ribs and their costal cartilages from one another. The name of each intercostal space is according to the rib that forms the superior border of the space. For example, the 6th intercostal space is between ribs 6 and 7. The space below the 12th rib doesn't lie between any ribs, so it's called the subcostal space. So, at the end of the day, the thoracic cage forms a complete wall peripherally, but it's open superiorly and inferiorly. The superior thoracic aperture, or opening, is smaller and allows communication with the neck and upper limbs, while the inferior thoracic aperture is larger and provides the ring-like origin of the diaphragm, which completely closes this opening. The superior thoracic aperture is bounded posteriorly by T1 vertebra, with its body protruding anteriorly into the opening. Laterally, there's the first pair of ribs and their costal cartilages. Anteriorly, there's the superior border of the manubrium. Structures that pass through the superior thoracic aperture include the trachea, esophagus, nerves, and vessels that supply and drain the head, neck, and upper limbs. The inferior thoracic aperture is bounded posteriorly by the 12th thoracic vertebra, and the body of this vertebra also protrudes anteriorly into the opening. Posterolaterally, there are the 11th and 12th pair of ribs. Anterolaterally, there are the joined costal cartilages of ribs 7 through 10, forming the costal margins. Anteriorly, there's the xiphosternal joint. The diaphragm closes the inferior aperture and separates the thoracic and abdominal cavities almost completely. The structures that pass to and from the thorax to the abdomen pass through openings that traverse the diaphragm, such as the esophagus and inferior vena cava, or pass posterior to the diaphragm, like the aorta. In this image, can you identify the borders of the superior thoracic aperture? How about the inferior thoracic aperture? Finally, the thoracic wall with all its bones and joints are essential during respiration, along with the diaphragm. They increase or decrease the intrathoracic volume and diameters of the thorax, resulting in changes of pressure. During expiration, the diaphragm, intercostal muscles, and other muscles relax, reducing the diameter of the thoracic wall and increasing intrathoracic pressure to expel air from the lungs. During inspiration, the vertical dimension of the thoracic cavity increases as contraction of the diaphragm causes it to descend inferiorly into the abdominal cavity. The AP dimension of the thorax also changes considerably during inspiration as the intercostal muscles contract. During intercostal contraction, the costotransverse joints of ribs 1 through 7 move around an axis passing through the neck of the ribs, causing the anterior sternal ends of the ribs to rise to create a pump handle movement. Additionally, the transverse dimension of the thorax also increases during inspiration as contraction of the intercostal muscles raises the middle, lateralmost parts of the lateral lower ribs to create a bucket handle movement made possible by the 8th through 10th costotransverse joints having flat articular surfaces which allow gliding. These combinations of movements allow the thoracic cage to move anteriorly, superiorly, and laterally to accommodate air inflow during inspiration. Alright, as a quick recap, the thoracic wall includes the thoracic cage and the muscles between the ribs and the skin, as well as subcutaneous tissue, muscles, and fascia that cover its anterolateral aspect. Of the 12 pairs of ribs, the first 7 pairs are true ribs, and they attach directly to the sternum through their own costal cartilages. The 8th, 9th, and usually the 10th rib are false, and their cartilages are connected to the cartilage of the rib above them. The 11th and 12th pair of ribs are floating ribs, and they're not connected to the sternum. The 3rd through 9th pair of ribs are typical ribs. The 1st, 2nd, and 10 through 12th ribs are atypical. The sternum has 3 parts: manubrium, body, and xiphoid process. The manubrium has a jugular notch, clavicular notches, and between the manubrium and body of the sternum is the manubriosternal joint. At this level, there's the sternal angle, which lies at the level of T4, T5 intervertebral disc, and marks the level of the second pair of costal cartilages. The xiphoid process lies at the level of T10 vertebrae. The ribs and their costal cartilages are separated from one another by the 11 intercostal spaces, and each space gets its name from the rib that forms the superior border of the space. The superior thoracic aperture allows passage of the structures between the thorax and the neck, while the inferior thoracic aperture is bounded inferiorly by the diaphragm and is where structures pass to and from the abdomen. Finally, during forced inspiration, the thoracic cage increases its vertical height through the diaphragmatic contraction. The antero-posterior diameter of the thoracic wall through a pump handle movement, and the transverse diameter through a bucket handle movement.
The lungs are a pair of air-filled organs located in the thoracic cavity on the left and right side, separated by a central mediastinum, which contains the heart, thoracic parts of the great vessels, thoracic parts of the trachea, esophagus, thymus, and other structures. It's also important to notice that the heart is turned and extends towards the left side of the thoracic cavity, imposing on the left lung markedly more than the right, so the anatomy of the two lungs is not completely symmetrical. Each lung is covered by a membrane called the pleura, which is subdivided into the visceral pleura that intimately adheres to the lung, and the parietal pleura that lines the pulmonary cavity. Between them, there's a pleural cavity, which is normally filled with a thin film of fluid. Now, on the medial part of each lung, there's a pulmonary hilum, where the root of the lung passes through. The root of the lungs is made up of structures like the main bronchus, arteries, and veins. The lungs are light, soft, and spongy, and each of them has an apex, a base, and three surfaces: costal, mediastinal, and diaphragmatic, and three borders: anterior, inferior, and posterior. The apex is the blunt superior end of the lung above the level of the first rib into the root of the neck, while the base is the concave inferior surface of the lung that rests on the diaphragm. Now for the specifics. The right lung is larger and heavier than the left, but it's shorter and wider because the right dome of the diaphragm is higher and the heart and pericardium are more to the left. The right lung is divided into three lobes: superior, middle, and inferior, by the horizontal fissure and the oblique fissure, which can be seen on all surfaces of the lung. On the other hand, the left lung has a single left oblique fissure, which can also be seen on all surfaces, and divides the left lung into two lobes, superior and inferior. Also on the left lung, there's a deep cardiac notch on the anterior border, caused by the deviation of the heart towards the left. This leaves an impression on the anterior-inferior aspect of the superior lobe, and also shapes a tongue-like process called the lingula. The lingula extends below the cardiac notch and goes in and out of the costomediastinal recess during breathing. Next, there are the lung surfaces. The costal surface of both lungs is large, smooth, and convex, and related to the costal pleura, which separates it from the ribs, costal cartilages, and intercostal muscles. The posterior part of the costal surface is in relation to the bodies of the thoracic vertebrae, sometimes called the vertebral part of the costal surface. The diaphragmatic surface of the lung, also concave, forms the base of the lung, which rests on the dome of the diaphragm. The concavity is deeper in the right lung because the right dome is higher due to the liver sitting below. Finally, the mediastinal surface of the lung is concave because it's related to the middle mediastinum, which contains the pericardium and heart. This surface includes the hilum, which receives the root of the lung. On an embalmed cadaver, several impressions can be seen on the mediastinal surface of the lung. On the right lung, there's a groove for the esophagus and arch of the azygos vein, as it arches superior to the lung hilum to drain into the superior vena cava, which may also cause a groove in the right lung. Both lungs also have a cardiac compression for the heart, where on the left lung, there's a much larger cardiac compression as the heart apex is directed towards the left. The left lung will also have a continuous groove for the arch of the aorta, as well as a descending aorta and a smaller area for the esophagus. And just a few words on borders. The anterior border is where the costal and mediastinal surfaces meet anteriorly. On the right lung, it's almost straight, while on the left lung, it's deviated by the cardiac notch. The inferior border is thin and sharp and bounds the diaphragmatic surface of the lung and separates it from the costal and mediastinal surfaces. It also projects into the costodiaphragmatic recess of the pleura. The posterior border is where the costal and mediastinal surfaces meet posteriorly, and it's broad and rounded, and lies at the side of the thoracic region of the vertebral column. The lungs are attached to the mediastinum by the roots of the lungs, made up by the bronchi and associated bronchial vessels, the pulmonary arteries, the superior and inferior pulmonary veins, as well as the pulmonary plexuses of nerves and lymphatic vessels. On a section of the right and left lung root, we can identify the position of the main bronchus and the pulmonary artery and vein in relationship to one another. But keep in mind there may be slight variations from person to person. First, the main bronchus is typically against the posterior middle boundary in both lung roots. Depending on the precise location of the section, you may see the main bronchus dividing into the superior lobar bronchus and intermediate bronchus on the right, and into the superior lobar bronchus and inferior lobar bronchus on the left. On anatomical dissection, the bronchus is easiest to identify due to its firm cartilaginous structure when feeling it. Second, the pulmonary artery is the superiormost structure on both the left and right roots. However, on the right side, you may see the first two branches of the pulmonary artery. Third, the superior and inferior pulmonary veins are typically the anteriormost and inferiormost structures on both lung roots. These roots enter and exit the lungs through a doorway that is called the hilum of the lung, similar to how the roots of a plant enter into the ground. Medial to the hilum, towards the central mediastinum, the lung root is enclosed within the area of continuity between the parietal and visceral layers of the pleura. Inferior to the root of the lung, this continuity between parietal and visceral pleura forms the pulmonary ligament, which extends between the lung and mediastinum, directly anterior to the esophagus. The pulmonary ligament consists of a double layer of pleura, separated by a small amount of connective tissue. To visualize this, think of wearing a large lab coat. Your forearm represents the root of the lung, and the sleeve is the pleura, which, if it's too large, will droop down in a double layer. Now let's play a game and see if you can tell which lung is which, based on their external appearance. Alright, now let's look at the tracheobronchial tree, which starts with the trachea right below the larynx. Below the larynx, the walls of the trachea are surrounded by C-shaped rings of hyaline cartilage. The trachea bifurcates into two main bronchi, or primary bronchi, at the level of the transverse thoracic plane, or sternal angle. They pass inferolaterally to enter the lungs at each hilum. The right main bronchus is wider, shorter, and has a more vertical trajectory than the left one, and passes directly into the right hilum. The left main bronchus passes inferolaterally, inferior to the aortic arch, and anterior to the esophagus and thoracic aorta to reach the left hilum. Now, within each lung, the main bronchi divide to form the branches of the tracheobronchial tree, all of which actually belong to the root of the lung. Each main bronchus divides into the secondary lobar bronchi, each of which supply a lobe of the lung. So on the right, there are three secondary lobar bronchi: right superior lobar bronchus, right middle lobar bronchus, and right lower lobar bronchus. The portion of the right main bronchus that continues inferiorly and gives rise to the middle and lower lobar bronchi is often referred to as the intermediate bronchus. On the left, there are only two lobar bronchi, the left superior lobar bronchus and the left inferior lobar bronchus. Each secondary lobar bronchus then divides into several tertiary segmental bronchi that supply the bronchopulmonary segments. Each bronchopulmonary segment is independently supplied by a tertiary segmental bronchus, in addition to a branch of the pulmonary artery. So there's 10 bronchopulmonary segments for the right lung and 8 to 10 for the left lung, as some of the segments may be combined. These bronchopulmonary segments are functionally distinct segments, which is important for surgeons who operate on lungs. In both lungs, the superior lobe has an apical, posterior, and anterior segment, where the apical and posterior segment may be combined on the left. Furthermore, the left superior lobe also has a superior lingular and inferior lingular segment. Because the right lung has a middle lobe, the middle lobe has a lateral and medial segment, which are the counterparts to the superior lingular and inferior lingular segments. Finally, both of the lung's lower lobes have a superior segment, along with an anterior, posterior, medial, and lateral basal segment, where in the left lung, the anterior and medial segments may be combined. Beyond the tertiary segmental bronchi, the tracheobronchial tree branches 20 to 25 more times, resulting in about 20 to 25 generations of branching conducting bronchioles. Finally, conducting bronchioles end as terminal bronchioles, which are the smallest conducting bronchioles and don't have any cartilage in their walls. Each terminal bronchiole gives rise to several generations of respiratory bronchioles, which have scattered alveoli, or thin-walled outpouchings, extending from their lumens. The pulmonary alveolus is the basic structural unit of gas exchange. Due to these tiny structures, the respiratory bronchioles can transport air and exchange gas. Each respiratory bronchiole gives rise to 2 to 11 alveolar ducts, each of which gives rise to 5 to 6 alveolar sacs. Alveolar ducts are elongated airways lined with alveoli, leading to the alveolar sacs where clusters of alveoli open. When thinking of the blood supply to the lungs, you need to consider two different circuits. First, they have a functional circulation, where low oxygen blood comes from the heart and reaches the lungs in order to exchange carbon dioxide with oxygen from all the tissues throughout the body. Then there's a nutritive circulation, which also comes from the heart, but this time, oxygenated blood nourishes the lungs themselves. Regarding functional or pulmonary circulation, briefly speaking, each lung has a pulmonary artery supplying low oxygen blood to it and two pulmonary veins draining oxygenated blood from it. The right and left pulmonary artery arise from the pulmonary trunk at the level of the sternal angle, and they carry low oxygen blood to the lungs. Although they're called arteries, they're colored blue just like veins in almost all anatomical illustrations, because they transport low oxygenated blood. Each pulmonary artery becomes part of the root and then divides into secondary lobar arteries. At this point, let's keep in mind that the arteries pair together with the bronchi and usually sit anterior to them. The right and left superior lobar arteries to the superior lobes arise first, even before entering the hilum. Continuing into the lung, the artery descends posteriorly and laterally to the main bronchus. In the right lung, it continues as the intermediate artery that will divide into middle and inferior lobar arteries. And in the left lung, it continues as the inferior lobar artery. Lobar arteries further divide into tertiary segmental arteries, which are what supply the bronchopulmonary segments. Two pulmonary veins, a superior and an inferior pulmonary vein on each side, carry oxygen-rich blood from the lungs to the left atrium of the heart. Because they carry oxygen-rich blood, they're colored red in medical illustrations. Unlike the pulmonary arteries, the pulmonary veins don't buddy up with respective bronchi and arteries. They just course within the lung, receiving oxygenated blood from adjacent bronchopulmonary segments. The veins from the visceral pleura and the bronchial venous circulation drain into the pulmonary veins, with the exception of the central perihilar region of the lung. This means that a small volume of low oxygen blood enters a large volume of oxygenated blood. Regarding the nutritive or bronchial circulation, there are two left bronchial arteries and a single right bronchial artery that supply the root of the lungs, tissues of the lungs, and the visceral pleura. The parietal pleura is typically supplied by the arteries supplying the thoracic wall. Now, the two left bronchial arteries usually arise from the thoracic aorta. The right bronchial artery usually arises either from the proximal part of one of the upper posterior intercostal arteries, usually the third posterior intercostal artery, or from a common trunk with the left superior bronchial artery. Sometimes a single right bronchial artery may arise directly from the aorta. The bronchial arteries also provide branches to the upper esophagus. The bronchial arteries pass on the posterior aspect of the main bronchi, and supply all the branches as far as the respiratory bronchioles. The most distal branches of the bronchial arteries anastomose with branches of the pulmonary arteries in the walls of the bronchioles and also in the visceral pleura. The right and left bronchial veins only drain the part of the blood that's distributed near the more proximal part of the root, and they also drain some blood from the esophageal veins. The right bronchial vein drains into the azygous vein, while the left bronchial vein drains into the accessory hemiazygous vein, or into the left superior intercostal vein. The blood returning from the visceral pleura, as well as from the more peripheral regions of the lung, and the distal components of the root, is drained by the pulmonary veins. While we're at it, let's not forget about the lymphatics of the lungs. First, there are two lymphatic plexuses, a superficial and a deep one, which communicate freely. The superficial or subpleural plexus lies deep to the visceral pleura and drains the visceral pleura and lung tissue. Lymphatic vessels from this plexus drain into the bronchopulmonary or hilar lymph nodes located in the region of the lung hilum. The deep lymphatic plexus is located in the submucosa of the bronchi and in the peribronchial connective tissue, and it drains the structures that make up the root of the lung. Lymphatic vessels here continue to follow the bronchi and pulmonary vessels in the hilum, where they also drain into the bronchopulmonary lymph nodes. At this point, lymph from both the superficial and deep plexi drain to the superior and inferior tracheobronchial lymph nodes, which are located superior and inferior to the bifurcation of the trachea. The right lung drains primarily through the consecutive nodes on the right side, and the superior left lobe drains primarily through the corresponding nodes on the left. However, a lot of the lymphatics from the lower lobe of the left lung drain to the right superior tracheobronchial nodes. Now, lymph from the tracheobronchial lymph nodes passes to the right and left bronchomediastinal lymph trunks, which are the major conduits that are draining the thoracic viscera. They usually end on each side at the venous angles, which are the junctions of the subclavian and internal jugular veins. Finally, lymph from the parietal pleura drains into the lymph nodes of the thoracic wall, and a few lymphatics from the cervical parietal pleura drain into the axillary lymph nodes. After having fun with the lymphatics, let's now tackle the nerves of the lungs and pleura. The nerves of the lungs and visceral pleura come from the pulmonary plexuses, located anterior and posterior to the roots of the lungs, and contain parasympathetic, sympathetic, and visceral afferent fibers. The parasympathetic fibers conveyed to the pulmonary plexus are presynaptic fibers from the vagus nerve. They synapse with the parasympathetic ganglion cells in the pulmonary plexuses and along the branches of the bronchial tree. The parasympathetic fibers are active during rest mode, so they cause bronchoconstriction of the smooth muscle in the bronchial tree, vasodilation of the pulmonary vessels through inhibition, and secretion of glands in the bronchial tree. The sympathetic fibers of the pulmonary plexuses are postsynaptic fibers. Their cell bodies are in the paravertebral sympathetic ganglia of the sympathetic trunks. The sympathetic fibers are active during the fight or flight mode, so they cause bronchodilation, vasoconstriction in the pulmonary vessels, and inhibit the secretion in the alveolar glands of the bronchial tree. The visceral afferent fibers of the pulmonary plexuses are either reflexive, meaning they coordinate an automatic response to a stimulus, or nociceptive, meaning they respond to painful stimuli. Reflexive fibers travel with the parasympathetic fibers and carry impulses responsible for reflexive control, such as coughing. Nociceptive fibers from the visceral pleura and bronchi accompany the sympathetic fibers and respond to painful stimuli. Finally, the nerves of the parietal pleura derive from the intercostal and phrenic nerves. The costal pleura and the peripheral part of the diaphragmatic pleura are supplied by intercostal nerves, which mediate both the sensation of touch and pain. The central part of the diaphragmatic pleura and the mediastinal pleura are supplied by the phrenic nerves. Alright, as a quick recap, the lungs are located on each side of the thorax and are covered by the pleura. They have an apex, a base, 3 surfaces, costal, mediastinal, and diaphragmatic, and 3 borders, anterior, inferior, and posterior. The right lung is divided by the horizontal fissure and oblique fissure into 3 lobes, while the left lung is divided by the left oblique fissure into 2 lobes, and, due to the cardiac notch, on the anterior-inferior aspect of the superior lobe, there's the lingula. The tracheobronchial tree begins below the larynx with the trachea, which splits into the main bronchi, which further split into secondary lobar bronchi, tertiary segmental bronchi, and at the tertiary level, the right lung can be divided into 10 bronchopulmonary segments, and the left lung into 8 to 10 bronchopulmonary segments. The tertiary segmental bronchi then split into conducting bronchioles, terminal bronchioles, and respiratory bronchioles, which contain the alveoli. The functional circulation of the lungs consists of the right and left pulmonary arteries, which supply oxygen-poor blood to the lungs, and the 4 pulmonary veins, which carry oxygen-rich blood back to the heart. The nutritive circulation is assured by the 2 left bronchial arteries and the single right bronchial artery. The right and left bronchial veins are responsible with venous drainage along with the pulmonary veins in some regions. Lymphatics of the lungs and pleura include the superficial and deep lymphatic plexuses. Finally, nerves come from the pulmonary plexuses and contain parasympathetic, sympathetic, and afferent fibers.
The mediastinum is the central compartment of the thoracic cavity, and it lies between the 2 pulmonary cavities. It's covered on each side by the mediastinal pleura and contains all thoracic viscera and structures minus the lungs. The mediastinum is divided into 4 parts, one of which is superior, and 3 that are inferior. The superior part is bounded superiorly by the thoracic aperture, and extends inferiorly to the transverse thoracic plane, which is a horizontal plane that extends from the sternal angle anteriorly and the junction of T4 and T5 posteriorly. The transverse thoracic plane separates the superior mediastinum from the inferior mediastinum and is also an important anatomical landmark representing the bifurcation of the trachea and the beginning and end of the arch of the aorta. The inferior mediastinum lies between the transverse thoracic plane superiorly and the diaphragm inferiorly. It's further subdivided by the pericardium into anterior, middle, and posterior parts, with the pericardium and its contents being in the middle part. So, in this video, let's focus on the superior mediastinum. From anterior to posterior, it contains the following structures: the thymus, the great vessels, the inferior continuation of the trachea, the inferior continuation of the esophagus, and the thoracic duct and lymphatic trunks. Now, let's take a closer look at some of these structures one by one. So, the thymus is located in the inferior part of the neck and in the anterior part of the superior mediastinum. It is a glandular structure, and it lies posterior to the manubrium and extends into the anterior mediastinum. The thymus is a primary lymphoid organ that plays a huge role in helping our immune cells develop before puberty. After puberty, however, it undergoes gradual involution and is mostly replaced by fat. Next up, there are great vessels. First, we have the veins, which include the brachiocephalic veins and the superior vena cava, or SVC, as well as the arteries, which include the arch of the aorta and its major branches, the brachiocephalic trunk, left common carotid artery, and left subclavian artery. Let's take a look at this picture and identify the left and right brachiocephalic veins, which form posterior to the sternoclavicular joints by the joining of the internal jugular and subclavian veins. Then, the brachiocephalic veins join to form the SVC at the level of the inferior border of the first right costal cartilage, with the left brachiocephalic vein being longer than the right one, since it has to travel farther to drain to the right side of the heart. Now, the SVC then passes inferiorly and ends at the level of the third costal cartilage, at which point it enters the right atrium. The SVC lies on the right side of the superior mediastinum, anterolateral to the trachea and posterolateral to the ascending aorta. The SVC is anterior to the root of the right lung, and the azygous vein drains into its posterior surface. Next up, there's the aortic arch, which continues the ascending aorta and begins at the level of the sternal angle, posterior to the second right sternocostal joint. As you can see in this picture, it arches superiorly, posteriorly, and to the left, and then inferiorly. The arch goes up anterior to the right pulmonary artery and the bifurcation of the trachea. It reaches its apex as it passes over the root of the left lung, at the left side of the trachea and esophagus. The arch descends posterior to the left root of the lung beside T4 and ends by becoming the thoracic or descending aorta posterior to the second left sternocostal joint. Now let's take a really quick break and see, can you recall the plane that the beginning and end of the arch of the aorta is divided by? That's right, we're talking about the transverse thoracic plane. Now, the branches of the aortic arch are the brachiocephalic trunk, left common carotid artery, and left subclavian artery. The brachiocephalic trunk is the first and largest branch of the aorta. It arises posterior to the manubrium, at which point it's anterior to the trachea and posterior to the left brachiocephalic vein. Then, it ascends superiorly and laterally to reach the side of the trachea and is found posterior to the right sternocostal joint, where it divides into the right common carotid and right subclavian artery. The left common carotid artery is the second branch of the aortic arch. It originates posterior to the manubrium, but slightly posterior and to the left of the brachiocephalic trunk. It ascends anterior to the left subclavian artery and enters the neck posterior to the left sternocostal joint. The left subclavian artery is the third branch of the aortic arch and has its origin in the posterior part of the arch, posterior to the left common carotid artery. It ascends through the superior mediastinum lateral to the left common carotid artery and enters the root of the neck by passing posterior to the left sternocostal joint. One last important structure to mention in the superior mediastinum is the ligamentum arteriosum. The ligamentum arteriosum is a fibrous band, which is an embryological remnant of the ductus arteriosus from birth, which acted as a shunt for blood to travel from the pulmonary trunk to the aortic arch in order to bypass the fetal lungs, which weren't functional in utero. The ligamentum arteriosum remains and passes from the superior portion of the proximal left pulmonary artery to the inferior surface of the aortic arch. Before moving forward, let's see if you can remember what the superior mediastinum contains from anterior to posterior. All right, so we're going to assume that you got that exactly right, so we can now move on to the nerves. As you can surely remember, there is a pair of vagus nerves which carry sensory, motor, and autonomic information to the mediastinum. They exit the cranium and go down through the neck, posterior and lateral to the common carotid arteries. They then enter the superior mediastinum, posterior to the left and right sternocostal joint and brachiocephalic vein. The right vagus nerve enters the thorax anterior to the right subclavian artery, at which point it gives rise to the right recurrent laryngeal nerve. This nerve goes around the right subclavian artery and ascends between the trachea and esophagus to supply the larynx. Back to the right vagus nerve. It runs postero-inferiorly through the superior mediastinum on the right side of the trachea, then passes posterior to the right brachiocephalic vein, SVC, and root of the right lung. At this point, it divides into many branches which contribute to the right pulmonary plexus. The right vagus nerve typically leaves this plexus as a single nerve and passes to the esophagus, where it gives many branches to contribute to the esophageal plexus. The right vagus nerve also gives rise to nerves that contribute to the cardiac plexus. The left vagus nerve descends in the neck posterior to the left common carotid artery, then enters the mediastinum between the left common carotid artery and left subclavian artery. When the left vagus nerve reaches the inferior border of the arch of the aorta, it curves medially and gives rise to the left recurrent laryngeal nerve. This nerve passes inferior to the aortic arch, lateral to the ligamentum arteriosum, which we talked about earlier, and climbs to the larynx in the groove between the trachea and the esophagus. The left vagus nerve passes posterior to the root of the left lung, where it gives many branches to contribute to the left pulmonary plexus. Then, the left vagus nerve leaves this plexus as a single trunk and goes to the esophagus, where it contributes to the esophageal plexus. Both vagus nerves eventually pierce the diaphragm at the T10 level along with the esophagus to provide further innervation to the abdomen. Next up, there's the paired phrenic nerves, which supply the diaphragm with both motor and sensory fibers, and they also supply the pericardium and mediastinal pleura with just sensory fibers. Quite the overachievers, I'd say. Each phrenic nerve reaches the superior mediastinum between the subclavian artery and the origin of the brachiocephalic vein. Unlike the vagus nerves, the phrenic nerves pass anterior to the root of the lungs. The right phrenic nerve passes along the right side of the right brachiocephalic vein, SVC, and the pericardium over the right atrium. It also passes anterior to the root of the right lung and descends on the right side of the inferior vena cava to the diaphragm. The left phrenic nerve descends between the left subclavian and left common carotid arteries, then crosses the aortic arch anterior to the left vagus nerve. Now, the left phrenic nerve descends anterior to the root of the left lung and runs along the fibrous pericardium, superficial to the left atrium and ventricle of the heart, and it pierces the diaphragm at the level of T8 to the left of the pericardium, providing innervation to it. The phrenic nerve is a mixed sensory and motor nerve, with contributions from spinal levels C3, C4, and C5. If the phrenic nerve becomes irritated where it innervates the diaphragm or parietal pleura, it can lead to something called referred pain to the dermatomes, supplied by the same spinal region the phrenic nerve originates from. So in this case, phrenic nerve irritation will cause a referred pain to the dermatomes of C3, C4, and C5, and this will manifest as root of the neck pain, which is C3 and C4, or shoulder tip pain, which is C5. This is why diaphragmatic or lung irritation can cause people to have shoulder tip pain, and this is a classic example to describe referred pain, similar to how heart attacks can cause a shooting pain in the neck or arm. Okay, now let's switch gears and look at the trachea, which descends anterior to the esophagus and enters the superior mediastinum. Looking at it in the median plane, it's positioned a bit to the right. The posterior surface of the trachea, which borders the esophagus, is flat, and the trachea ends and divides into the right and left main bronchi at the level of the sternal angle marked by T4 and T5 junction. And finally, the esophagus is a fibromuscular tube that extends from the pharynx to the stomach. It enters the superior mediastinum between the trachea and vertebral column, lying anterior to the bodies of T1 through T4. Typically, the esophagus is flattened anteroposteriorly. To the left side of the esophagus, there's the thoracic duct, which is also medial or deep to the aortic arch. Inferior to the aortic arch, the esophagus passes in the diaphragm through the esophageal hiatus. All right, as a quick recap, the mediastinum is divided into the superior mediastinum and an inferior mediastinum, where the inferior mediastinum is further subdivided into the anterior, middle, and posterior mediastinum. The superior mediastinum lies between the thoracic aperture superiorly and the transverse thoracic plane inferiorly. From anterior to posterior, the superior mediastinum contains the thymus, the great vessels, the inferior continuation of the trachea, the inferior continuation of the esophagus, and lymphatic trunks.
The pleura is a thin membrane that covers each of our lungs and surrounding pulmonary cavity, and it can be subdivided into two layers. The visceral pleura, which intimately adheres to the lungs, and the parietal pleura, which lines the rest of the pulmonary cavity. Between these two pleural layers, there's the pleural cavity, which is normally filled with a thin film of fluid in order to lubricate the pleural surfaces and allow them to slide smoothly over each other during each breath. Now, on the medial part of each lung, there's a pulmonary hilum, where the root of the lung passes through. The root of the lungs is made of structures like the tracheobronchial tree, as well as arteries and veins. At this level, the visceral and parietal pleura are continuous, making just one structure. To make this easier, you can imagine an underinflated balloon through which you press your fist into. The fist representing the root of the lung, and the balloon representing the visceral and parietal pleura. As you can see, the parietal and visceral pleura are one continuous layer. However, they are reflected on different surfaces. Now, the visceral pleura covers the entire lung and adheres intimately to all of its surfaces, including the ones between the fissures of each lung. The visceral pleura is continuous with the parietal pleura at the hilum of the lung. The parietal pleura is thicker than the visceral one, lines the pulmonary cavities, and adheres to the thoracic wall, mediastinum, and diaphragm. The parietal pleura actually has 4 parts: costal, mediastinal, diaphragmatic, and cervical pleura. The costal pleura covers the internal surface of the thoracic wall, from which it's separated by the endothoracic fascia, a thin layer of loose connective tissue that comes in handy during surgical procedures, making it really easy to separate the lungs from the thoracic wall. The mediastinal pleura covers the lateral aspects of the mediastinum, which is a space between the lungs and continues as cervical pleura superiorly in relation to the root of the neck. It's also continuous inferiorly with the diaphragmatic pleura, and with the costal pleura anteriorly and posteriorly. At the hilum, the mediastinal pleura changes direction laterally onto the root of the lung to become one with the visceral pleura. Superior to the hilum is a continuous sheet passing between the sternum and vertebral column. The diaphragmatic pleura covers the superior surface of the diaphragm on each side of the mediastinum, minus where the diaphragm is fused with the pericardium, and minus the diaphragm's costal attachments to the xiphoid process anteriorly, and to the 11th and 12th rib laterally. Finally, the cervical pleura is basically a continuation of the costal and mediastinal pleura and covers the apex of the lungs, which is the part that extends through the superior thoracic aperture into the root of the neck. Over the apex, the cervical pleura forms the pleural cupula, which domes over the apex that reaches its crest at about 2 to 3 centimeters superior to the clavicle at the level of the neck's first rib. The cervical pleura is made stronger by a fibrous extension of the endothoracic fascia, called the suprapleural membrane. This membrane attaches to the internal border of the first rib and the transverse process of C7 vertebra. So you see, the parietal pleura covers many different thoracic surfaces, and in doing so, creates different lines called lines of pleural reflection. There are 3 lines of pleural reflection on each side of the pulmonary cavities: sternal, costal, and vertebral. By understanding these pleural lines of reflection and how to find them with surface anatomy landmarks, we can locate the boundaries of the pleural cavity, which is important during clinical interventions needed to access the pleural space between the parietal and visceral pleura. The sternal lines of reflection occur anteriorly at the point where the costal pleura is continuous with the mediastinal pleura. They start superiorly from the cupula and descend inferior-medially, pass posterior to the sternoclavicular joints, and meet at the anterior median line, at which point they descend together between the levels of costal cartilages 2 through 4, and then they split up again. At this point, the sternal lines become asymmetrical, because the heart is positioned more to the left, so it leaves a bigger impression on the left lung. So, the right sternal line continues to descend along the anterior medial line, posterior to the xiphoid process, at which point it turns laterally and becomes a costal line. The left sternal pleural reflection descends on the anterior medial line only to the level of the 4th costal cartilage, and at this point, it passes to the left margin of the sternum and continues to the 6th costal cartilage, creating a notch as it runs lateral to the bare area of the pericardium, located roughly at the left side of the midclavicular line. And this is where the pericardium is in contact with the anterior thoracic wall. At this point, the sternal line becomes the costal line. Now, the costal lines continue the sternal lines, and they occur at the point where the costal pleura becomes continuous with the diaphragmatic pleura inferiorly. So the right costal line continues its journey from the anterior medial line. The left costal line continues its journey near the midclavicular line because of the bare area of pericardium on the left. Other than this, the right and left costal lines are symmetrical. They continue to descend posteriorly, and then they make a turn around the 8th rib at the midclavicular lines, and then another turn in the 10th rib at the mid-axillary lines, and then become continuous posteriorly with the vertebral lines at the necks of the 12th ribs. Finally, the vertebral lines of pleural reflection occur more gradually where the costal pleura becomes continuous with the mediastinal pleura posteriorly. The vertebral lines are parallel to the vertebral column and run in the paravertebral planes from T1 through T12. Afterwards, they become continuous with the costal lines. Now, during expiration, the lungs don't occupy the entire pulmonary cavities, so the diaphragmatic pleura is in contact with the lowest part of the costal pleura. These pleural spaces are called the costodiaphragmatic recesses, which act as gutters lined in pleura, and they surround the upward convexity of the diaphragm in the thoracic wall. There are also some smaller pleural recesses that are located posterior to the sternum where the costal pleura is in contact with the mediastinal pleura, and these are called costomediastinal recesses. The left recess is larger because it's less occupied due to the cardiac notch in the left lung. Now, let's catch a breath with a pop quiz. Can you recall the 4 parts of the pleura, as well as the lines of pleural reflection? Alright, as a quick recap. The lungs are located on each side of the thorax and are covered by the pleura. The visceral pleura adheres intimately to the lung, and the parietal pleura lines the pulmonary cavities. Between them, there's a thin film of fluid located within the pleural cavity, which allows for lubrication during respiration. Now, the parietal pleura has 4 parts: costal, mediastinal, diaphragmatic, and cervical pleura. When the parietal pleura changes direction, it forms 3 lines of pleural reflection: sternal, costal, and vertebral. The lungs don't occupy the entire pulmonary cavity during expiration, and as a consequence, the pleural spaces remaining form the costodiaphragmatic recesses and the costomediastinal recesses.
As we know, the mediastinum is divided into the superior mediastinum and the inferior mediastinum. The superior mediastinum is separated from the inferior mediastinum by the transverse thoracic plane, which is a horizontal plane that extends from the sternal angle anteriorly and the junction of T4 and T5 posteriorly, an important anatomical landmark representing the bifurcation of the trachea and the beginning and end of the arch of the aorta. The inferior mediastinum lies between the transverse thoracic plane superiorly and the diaphragm inferiorly, and is further subdivided by the pericardium into anterior, middle, and posterior parts. So first, let's look at the posterior mediastinum. It is located anterior to the T5 through T12 vertebrae, posterior to the pericardium and diaphragm, inferior to the transverse thoracic plane, and between the parietal pleura of the lungs. The posterior mediastinum contains the thoracic aorta, thoracic duct and lymphatic trunks, posterior mediastinal lymph nodes, azygous and hemiazygous veins, the esophagus, and the esophageal nerve plexus. The thoracic aorta continues the aortic arch, and it begins on the left side of the inferior border of the body of T4, moving downwards in the posterior mediastinum on the left side of T5 through T12 vertebrae. On its way down, the thoracic aorta is close to the median plane and moves the esophagus towards the right. The thoracic aorta lies posterior to the root of the left lung, pericardium, and esophagus, and is surrounded by the thoracic aortic plexus. Anterior to the inferior border of the T12 vertebra, it continues on as the abdominal aorta and enters the abdomen through the aortic hiatus in the diaphragm. The thoracic duct and azygos vein climb on the right side of the thoracic aorta and accompany it through the aortic hiatus. The vascular branches of the thoracic aorta are the esophageal arteries, which supply the esophagus, the bronchial arteries, which supply the lungs, the 9 pairs of posterior intercostal arteries that supply all the intercostal spaces except for the upper 2, and the subcostal arteries which supply the muscles and skin below the 12th rib. Other branches include the superior phrenic arteries, which supply part of the diaphragm, and pericardial branches, which help supply the pericardium. Now, the posterior mediastinum also contains the inferior portion of the esophagus as it continues its course from the superior mediastinum. In the posterior mediastinum, the esophagus passes posterior and to the right of the aortic arch and posterior to the pericardium and left atrium, so it's the main structure posterior to the base of the heart. Then it deviates to the left and passes through the esophageal hiatus in the diaphragm at the level of T10, and at this point it's anterior to the aorta. Remember that the thoracic aorta passes through the diaphragm at the level of T12 and the esophagus passes at level T10. It's also important that the inferior vena cava ascends through the diaphragm at level T8. To remember these anatomical landmarks, think of the phrase, "I ate 10 eggs at 12. The I represents the IVC at 8, the eggs represent the esophagus at T10, and the at 12 is aorta at T12. Also remember, the phrenic nerve pierces level T8 along with the IVC, the vagus nerve pierces T10 along with the esophagus, and the thoracic duct pierces at level T12 along with the aorta. Now, the esophagus may have 3 anatomic impressions or constrictions in the posterior mediastinum caused by 3 structures it meets on its way down: the aortic arch, the left main bronchus, and the diaphragm. These narrowings can be seen in oblique chest radiographs if a person were to undergo a barium swallow study. Also know that there is another potential constriction of the proximal esophagus prior to it entering the posterior mediastinum at the level of the cricoid cartilage. Remember that the surface esophagus is covered by the esophageal plexus, which is derived from the left and right vagus nerves as they descend through the superior and posterior mediastinum. The esophageal plexus goes on to form the anterior and posterior vagal trunk found on the inferior esophagus just before the esophagus passes through the diaphragm. These vagal trunks pass through the diaphragm with the esophagus and go on to innervate a large part of the GI tract. Let's now tackle the veins of the azygos venous system. It's located on each side of the vertebral column, and it drains the back, the thoracoabdominal walls, and the mediastinal viscera. Now, this system contains the azygos vein, the hemiazygos vein, and accessory hemiazygos veins. So, the azygos vein travels proximally up the posterior mediastinum and forms a collateral pathway from the posterior aspect of the inferior vena cava at the level of the renal veins. In the posterior mediastinum, the azygos vein passes close to the right side of the bodies of the inferior 8 thoracic vertebrae, posterior to the root of the right lung. Then it arches over the superior aspect of the root of the right lung to join the superior vena cava. The azygos vein also receives the mediastinal, esophageal, and bronchial veins. Now, the hemiazygos vein originates on the left side of the vertebral column, posterior to the thoracic aorta as far as the T9 vertebra. At this point, it crosses to the right, posterior to the aorta, thoracic duct, and esophagus, and joins the azygos vein. It receives the inferior 3 posterior intercostal veins, the inferior esophageal veins, and many small mediastinal veins. The accessory hemiazygos vein originates at the medial end of the 4th or 5th intercostal space and goes down on the left side of the vertebral column from T5 through T8. It receives blood from veins in the 4th through 8th intercostal spaces and sometimes even from left bronchial veins. It crosses over the T7 or T8 vertebra, posterior to the thoracic aorta and thoracic duct, at which point it joins the azygos vein. Okay, Let's now talk about the thoracic duct, which is the largest lymphatic channel in the body and conveys most of the lymph in the body to the venous system, specifically all lymph except from the right superior quadrant of the body. In the posterior mediastinum, it lies on the anterior part of the bodies of T12 to T5. The thoracic duct originates from the cisterna chyli in the abdomen and enters the mediastinum through the aortic hiatus in the diaphragm at the level of T12. It then goes up in the posterior mediastinum among the thoracic aorta on its left, the azygos vein on its right, the esophagus anteriorly, and the vertebral bodies posteriorly. At the level of T4, T5, or T6, the thoracic duct crosses to the left, becoming posterior to the esophagus, and enters the superior mediastinum. The thoracic duct typically empties into the venous system close to the joining of the left internal jugular and subclavian veins at a point called the left venous angle, or origin of the brachiocephalic vein. Now, the lymph nodes of the posterior mediastinum lie posterior to the pericardium, close to the esophagus and thoracic aorta. Some nodes lie posterior to the inferior part of the esophagus, but most of them lie anterior and lateral to it. The posterior mediastinal lymph nodes receive lymph from the esophagus, the posterior aspect of the pericardium and diaphragm, and the middle posterior intercostal spaces. Lymph eventually collects into the thoracic duct from these nodes on their way to the left venous angle, or depending on location, lymph may also drain into the right lymphatic duct to drain into the right venous angle. Next up, there are the nerves of the posterior mediastinum, namely the thoracic sympathetic trunks and their ganglia, which form a major portion of the autonomic nervous system. In the superior part of the thorax, the thoracic trunks lie against the heads of the ribs. In the mid-thorax, they lie against the costovertebral joints, and in the inferior part of the thorax, they lie on the sides of the vertebral bodies. The sympathetic trunk has one sympathetic ganglion for each thoracic vertebral level, and each ganglion is connected to their respective intercostal nerves via two rami communicantes. These two rami are the afferent white rami and the efferent gray rami. White rami carry preganglionic sympathetic fibers from the spinal nerves to the sympathetic ganglia, while gray rami carry postganglionic sympathetic fibers from the sympathetic ganglia to the spinal nerves. Preganglionic sympathetic fibers only originate from the T1 to L2 spinal levels, so there are no white rami above T1 or below L2 or L3, so sympathetic fibers ascend or descend the sympathetic trunk in order to provide sympathetic innervation from our heads down to our toes. This is possible because the thoracic sympathetic trunk is continuous with the cervical trunk above and lumbar sympathetic trunk below, both of which don't have white rami communicantes. Now, distally, the sympathetic trunks give rise to the lower thoracic splanchnic nerves, specifically the greater from T5 to T9, lesser from T10 and T11, and least splanchnic nerves coming from T12, which descend into the abdomen and supply the abdominal viscera. They have presynaptic fibers from the 5th through the 12th sympathetic ganglia that pass through the diaphragm and synapse in prevertebral ganglia in the abdomen, which go on to supply abdominal viscera below the diaphragm. Okay, let's take a quick break and see if you can remember what are the limits of the posterior mediastinum and the structures it contains. Next, let's focus on the middle mediastinum, which includes the pericardium, heart, and roots of its great vessels, such as the ascending aorta, pulmonary trunk, and superior vena cava. Let's take a look at the pericardium, which is a fibroserous membrane that covers the heart and the beginning of its great vessels. It's a closed sac with two layers, an external one called the fibrous pericardium and an internal one called the serous pericardium. The external layer is continuous superiorly with the tunica adventitia of the great vessels and the pretracheal layer of the deep cervical fascia. It's attached anteriorly to the posterior surface of the sternum through the sternopericardial ligaments, and it is continuous inferiorly with the central tendon of the diaphragm. The fibrous pericardium is lined with a serous membrane called the parietal layer of the serous pericardium. This layer is reflected onto the heart and its great vessels as the visceral layer of the serous pericardium. Now, the visceral layer of the serous pericardium forms the epicardium, which is the external layer of the heart. It extends onto the beginning of the great vessels and becomes continuous with the parietal layer of the serous pericardium. Within the pericardial cavity, which is a potential space formed between the parietal and visceral pericardial layers, the transverse pericardial sinus is a running passage between the vessels that leave the heart, specifically the aorta and pulmonary trunk, and the vessels that enter the heart, specifically the superior vena cava, the inferior vena cava, and pulmonary veins. The oblique pericardial sinus is the reflection of the serous pericardium around the vessels that enter the heart, bounded laterally by the IVC and pulmonary veins, forming a pouch that can be accessed inferiorly. The arterial supply of the pericardium comes from the pericardiophrenac artery, which is a branch of the internal thoracic artery. This branch usually accompanies or parallels the phrenic nerve to the diaphragm. Other arteries include the musculophrenic artery, which is a terminal branch of the internal thoracic artery, the bronchial, esophageal, and superior phrenic arteries, which are branches of the thoracic aorta, and finally the coronary arteries, which are the first branches of the aorta. The venous drainage of the pericardium is handled by pericardiophrenac veins, which are tributaries of the brachiocephalic veins and various tributaries of the azygous venous system. The nerve supply of the pericardium mainly comes from the phrenic nerves, which are primary sources of sensory fibers and pain sensations, which are referred to the skin on the C3 through C5 dermatomes of the ipsilateral supraclavicular region. Other fibers come from the vagus nerves and the sympathetic trunks. Can you remember the course of the phrenic nerves? Correct, anterior to the lung hilum and over the pericardium towards the diaphragm. How about the vagus nerve? Correct, behind the lung hilum to the esophagus. Finally, the anterior mediastinum, which is the smallest subdivision of the mediastinum, lies between the body of the sternum and the transversus thoracis muscles anteriorly and the pericardium posteriorly. The anterior mediastinum consists of loose connective tissue, fat, lymphatic vessels, few lymph nodes, and branches of the internal thoracic vessels. In children, it also contains the inferior part of the thymus. Alright, as a quick recap, the mediastinum is divided into the superior mediastinum and an inferior mediastinum, which are separated from each other by the transverse thoracic plane. The inferior mediastinum is bounded inferiorly by the diaphragm and is further subdivided into anterior, middle, and posterior mediastinum. The posterior mediastinum is located anterior to T5 through T12 vertebrae, posterior to the pericardium and diaphragm, inferior to the transverse thoracic plane, and between the parietal pleura of the lungs. It contains the following structures: thoracic aorta, thoracic duct and lymphatic trunks, posterior mediastinal lymph nodes, azygous and hemiazygous veins, esophagus and the esophageal nerve plexus. The middle mediastinum includes the pericardium, heart, and roots of its great vessels, such as the ascending aorta, pulmonary trunk, and superior vena cava. The anterior mediastinum lies between the body of the sternum and the transversus thoracis muscles anteriorly and the pericardium posteriorly. The anterior mediastinum consists of loose connective tissue, fat, lymphatic vessels, few lymph nodes, and branches of the internal thoracic vessels.
The heart is a muscular organ just slightly bigger than a person's loosely clenched fist. It's located in the thorax, more specifically between the two lungs, in a space called the mediastinum. The heart is covered by a tough membrane called the pericardium that separates the heart from the other structures in the mediastinum. This position allows the heart to do its job, which is to pump oxygen-rich blood to the entire body and to send poorly oxygenated blood to the lungs, where gas exchange can take place. The heart is made up of 4 chambers, and as a whole can be functionally divided into the right heart, made up of the right atrium and the right ventricle, and a left heart, made up of the left atrium and left ventricle. Both atria have pouch-like protrusions called auricles, which can increase the capacity when needed. Okay, now poorly oxygenated blood from our bodies and other tissues enters the right atrium through the superior vena cava and inferior vena cava. From there, blood passes into the right ventricle, which pumps into the pulmonary trunk on a voyage towards the lungs and is considered part of the pulmonary circulation. On the other hand, after gas exchange takes place in the lungs, oxygenated blood returns from the lungs through 4 pulmonary veins, which drain into the left atrium. Then, oxygenated blood goes in the left ventricle, and from there it's pumped into the aorta so that it reaches the whole body and is considered part of the systemic circulation. So looking at it in 3 dimensions, the heart looks like an upside-down, tipped-over pyramid with 4 sides, a base that's mostly posterior, and an apex or tip that points anteriorly and slightly to the left. On an anterior or posterior view in 2 dimensions, the heart is shaped like a trapezoid, so it has a superior and inferior as well as a right and left border. It's important to understand what comprises the borders of the heart, because the heart is rotated to the left on its longitudinal axis within the mediastinum, so the apex is directed more posterolaterally. The superior border is formed by the right and left atria. Along the superior border, from right to left, there's the superior vena cava, which enters the right atrium. Then there's the ascending aorta, which emerges from the left ventricle and then curves posteriorly to form an arch, called the aortic arch. Finally, there's the pulmonary trunk and its 2 branches, the right and left pulmonary artery, with the right pulmonary artery going under the aortic arch. The inferior border is almost horizontal, and is made up mainly by the right ventricle and part of the left ventricle. The right border is made up by the right atrium, and it's between the superior and inferior vena cava. And finally, the left border is mainly made up by the left ventricle and part of the left auricle. Now pay a bit of attention here, because the end of the inferior border, along with the lower part of the left border, make up the apex of the heart, which represents the tip of the left ventricle. Some of these features can also be identified on a posterior-anterior chest X-ray. The heart silhouette is between the lungs, and the right border made up by the right atrium, as well as the left border made up by the left ventricle and part of the left auricle, can be clearly seen. Finally, medial to the left auricle, there's the pulmonary trunk, which emerges from the right ventricle and branches into the left and right pulmonary arteries, with the right pulmonary artery going under the aortic arch. Now, let's identify the structures in an anterior and posterior view. On an anterior view, we can identify several structures, starting with the 4 chambers and ending with the great vessels. From right to left, there's most of the right atrium located superiorly and inferiorly to it, the right ventricle. They're separated by the coronary sulcus, also called the atrioventricular groove, or AV groove for short. Then, there's the auricle of the left atrium and the left ventricle, which are also separated by the coronary sulcus. The right ventricle and left ventricle are separated by the anterior interventricular sulcus. Moving on, you can actually see parts of the great vessels on an anterior view. So from right to left, there's part of the superior vena cava, which opens in the superior part of the right atrium. Then there's part of the inferior vena cava, which also opens in the right atrium, but the opening can only be seen on a posterior view. Then there's the ascending aorta, which emerges from the left ventricle and then arches toward the back to form the aortic arch. The branches of the aortic arch can also be seen, and from right to left, they are the brachiocephalic trunk, which branches into the right subclavian artery and right common carotid artery, the left common carotid, and the left subclavian artery. Finally, medial to the left auricle, there's the pulmonary trunk, which emerges from the right ventricle and branches into the left and right pulmonary arteries, with the right pulmonary artery going under the aortic arch. Interestingly enough, the superior portion of the proximal left pulmonary artery is connected to the inferior surface of the aortic arch by the ligamentum arteriosum. Even though this fancy-termed element is just a fibrous band now, back during embryological development, it used to connect the aortic arch and the pulmonary trunk as an adaptation of fetal circulation to intrauterine life. Now, on a posterior view, we can see the left atrium and the left auricle, most of the left ventricle, as well as the right atrium and right ventricle. As before, the atria and ventricles are separated by the coronary sulcus, but now the right and left ventricle are separated by the posterior intraventricular sulcus. In the upper portion, above the coronary sulcus, there are the great vessels. The left and right pulmonary veins, which bring oxygenated blood into the left atrium, and the left and right pulmonary arteries, which emerge from the pulmonary trunk and bring deoxygenated blood to the lungs above them, the aortic arch, and the superior and inferior vena cava. It's also important to visualize that the most anterior portion of the heart is the right ventricle, and the most posterior part of the heart is the left atrium, which lies directly anterior to the esophagus. And time for a pop quiz. What are the borders of the heart and what structures form them? Very well, let's get back at it. Now let's have a look at each chamber of the heart, starting with the right atrium. This is a right anterolateral view of the heart, where we dissected the right atrium in order to see its contents. The right atrium has a smooth, thin-walled posterior part called the sinus venerum, where both superior and inferior vena cava, as well as the coronary sinus, open. Then there's a rough, muscular anterior part formed by the pectinate muscles. Externally, the smooth and rough parts of the atrium are separated by a vertical, shallow groove called the sulcus terminalis. Internally, these structures are separated by a vertical ridge called the crista terminalis. Inferiorly, you can also see the right AV orifice, also known as the tricuspid orifice, which is where the blood from the atrium goes into the ventricle. Now, the superior vena cava enters through the superior part of the right atrium, which is roughly at the level of the third costal cartilage. The inferior vena cava opens inferiorly almost parallel to the superior vena cava, roughly at the level of the fifth costal cartilage. Finally, the coronary sinus opens between the tricuspid orifice and the inferior vena cava orifice. Now, the right and left atrium are separated by the intraatrial septum, which has a depression called the oval fossa, or fossa ovalis, which is a remnant of the oval foramen, or foramen ovale, that connected the atria during embryological development. In fetal life, oxygen-rich and nutrient-rich blood travels directly into the left atrium from the right atrium via the foramen ovale to bypass the pulmonary circulation. Let's stay on the right track and move into the right ventricle. Just like before, we're going to look at an anterior view of the heart where we dissected the right ventricle. The right ventricle has an inflow part where blood gets inside the ventricle, an outflow part through which blood leaves the right ventricle. The inflow part has muscular elevations called the trabecula carne, and the outflow part is formed by an infundibulum called the conus arteriosus, located superiorly and leads to the pulmonary trunk. So far, so good. Now, the right ventricle receives blood from the right atrium through the tricuspid orifice, which is posterior to the body of the sternum at the level of the fourth and fifth intercostal space. The tricuspid orifice is surrounded by a fibrous ring that's part of a fibrous skeleton of the heart, keeping its shape constant. And in order for blood to flow from the right atrium to the right ventricle at exactly the right time during each heartbeat, there's a tricuspid valve attached to the tricuspid orifice. It's called the tricuspid valve because it has 3 cusps or leaflets that open and close during systole and diastole. An anterior one, a posterior one, and a septal one. The base of each cusp is attached to a fibrous ring, while the free edges of the cusps are attached to tendinous cords called the chordae tendineae. These chordae tendineae anchor the leaflets to the papillary muscles, which are projections of the right ventricle. The anterior papillary muscle is the largest one and arises from the anterior wall of the right ventricle. Its chordae tendineae attach to the anterior and posterior cusps of the valve. Then there's the posterior papillary muscle that arises from the inferior wall of the right ventricle. Its chordae tendineae attach to the posterior and septal cusps. And finally, there's the septal papillary muscle, which arises from the intraventricular septum and chordae tendineae attached to the anterior and septal cusps. This smart and complicated mechanism is mainly meant to block the backflow of blood from the right ventricle to the right atrium during systole, which is when the heart contracts to pump blood out of the ventricles. Okay, we're not done with the right ventricle. Hang in there. The intraventricular septum, or IVS, separates the 2 ventricles and forms a part of the wall of each ventricle. It's made up of muscular and membranous parts. Now, the muscular part of the IVS is mostly part of the left ventricle, so it's 2 to 3 times thicker than the rest of the right ventricle. The membranous part is a thin membrane that's part of the fibrous skeleton of the heart, and it's located superiorly and posteriorly. On the right side of the IVS, the septal cusp of the tricuspid valve attaches to the middle of the membranous part. Finally, in the right ventricle, there's also a muscular bundle that crosses from the inferior part of the IVS to the base of the anterior papillary muscle. This is called the moderator band, or septomarginal trabecula, and it helps the right ventricle contract properly by making the anterior papillary muscle contract at the same time as the other 2 papillary muscles. So, to put all these structures into perspective, let's briefly talk about blood flow. The right atrium contracts when the right ventricle is empty and relaxed. So blood from the right atrium passes through the tricuspid valve and enters the right ventricle. Finally, blood then leaves the right ventricle through the pulmonary valve, which is located at the level of the 3rd costal cartilage, and enters the pulmonary trunk where blood is sent to the lungs for oxygenation. Okay, now let's pause for a heartbeat and see if you can identify the structures that make up the right atrium and ventricle. Okay, if you didn't get them all right, no worries. We can go left now, starting with the left atrium. The left atrium is slightly thicker than the right atrium, and along with the left auricle and the pectinate muscles within, it forms a large part of the base of the heart. The rest of the left atrium is smooth. The 4 pulmonary veins, namely the left superior, left inferior, right superior, and right inferior pulmonary veins, enter the smooth part of the left atrium posteriorly. Unlike other structures of the heart, the pulmonary veins don't have any valves and blood flows through them and into the left atrium freely. Now, on the intraatrial septum, there's a semilunar depression indicating the floor of the oval fossa, with a surrounding ridge being the valve of the oval fossa, which, as we mentioned before, used to represent a communication between the atria during embryonic development. Finally, inferiorly, there's a left AV orifice, or mitral orifice, through which blood flows from the left atrium into the left ventricle. Finally, let's look at the left ventricle, which forms the apex of the heart. Since the pressure inside the left ventricle is higher, its walls are 2 to 3 times as thick as those of the right ventricle. The left ventricular walls have more, but finer, trabeculae carnae than the right ventricle. It also has a smooth-walled, non-muscular part, which is called the aortic vestibule, which leads to the aortic orifice and aortic valve. The aortic valve is located posterior to the left of the sternum at the level of the 3rd intercostal space. The mitral orifice is surrounded by the mitral valve, which is located posterior to the sternum at the level of the 4th costal cartilage. The mitral valve is also referred to as a bicuspid valve, as it only has 2 cusps, anterior and posterior, compared to the 3 cusps of the tricuspid valve. Each of the cusps are attached to the papillary muscles through chordae tendineae, which allow the cusps to resist the high pressure during heart contraction. Now that we're done with the heart chambers, we'll now take a look at the pulmonary trunk and aorta. Blood flows from the right ventricle to the pulmonary trunk via the pulmonary semilunar valve, while blood flows from the left ventricle to the ascending aorta via the aortic semilunar valve. These valves each have 3 cusps, called the semilunar cusps. The pulmonary valve has an anterior, a right, and left cusp, while the aortic valve has a posterior, right, and left cusp. Unlike the tricuspid and mitral valves, the semilunar valves are smaller and don't have chordae tendineae to support them. Instead, during ventricular relaxation, blood is forced backwards into the heart where the cusps catch this reverse blood flow and snap closed like an umbrella caught in the wind. The cusp's edge come together to close the semilunar valves and support each other as their edges meet to prevent backflow. The edge of each cusp is thickened where they meet, forming the lunule, and at the apex of the angulated free edge, they form the nodule. During ventricular contraction, the semilunar valves open as they are pressed towards the walls of the pulmonary trunk and aorta. Superior to each semilunar cusp, the walls of the origins of the pulmonary trunk and the aorta are a bit dilated, forming a sinus where blood gets in to prevent the cusp from sticking to the wall of the vessel when they open, and it also helps them close back up. The sinus formed above the right aortic cusp is the origin of the right coronary artery, and the sinus formed above the left aortic cusp is the origin of the left coronary artery, both of which nourish the heart muscle. During ventricular relaxation, when the semilunar valves are closing, the backflow of blood towards the heart fills these sinuses, and the force of this backflow is what allows the left and right coronary arteries to fill. Now, before going any further, let's take a look at the conducting system of the heart, which consists of nodal tissue that automatically generates and transmits impulses that produce coordinated contractions of the heart muscle, effectively turning the heart into a pump. One special nodal tissue is the sinoatrial or SA node, located anterolaterally at the junction of the superior vena cava and right atrium, near the superior end of the sulcus terminalis. The SA node is the pacemaker of the heart, and it establishes the basic heart rhythm. Then, there's the atrioventricular or AV node, which is a smaller bit of nodal tissue located in the posterior-inferior region of the intraatrial septum near the opening of the coronary sinus. The way it goes is that the SA node initiates an impulse that's conducted in the atria, making them contract. The impulse then spreads to the AV node, and afterwards, the AV node spreads the impulse to the ventricles through the AV bundle. Finally, at the junction of the membranous and muscular part of the IVS, the AV bundle spreads into a right and left branch that further stimulates the IVS, and then the respective ventricles through smaller branches, called the Purkinje fibers. This way, the ventricles can contract effectively. And that's the basic electrophysiology of how the heart coordinates its contractions so blood can leave the heart and reach every organ in the body. The heart is supplied by the cardiac plexus, which is most commonly found on the anterior surface of the bifurcation of the trachea, posterior to the ascending aorta and the bifurcation of the pulmonary trunk. The cardiac plexus has both sympathetic and parasympathetic fibers, as well as visceral afferent fibers for the reflexive and nociceptive or pain-sensing fibers of the heart. The fibers of the cardiac plexus run along the coronary vessels and conducting system. Sympathetic innervation is from presynaptic fibers with cell bodies found in the superior 5 to 6 thoracic segments of the spinal cord, and postsynaptic sympathetic fibers with cell bodies in the cervical and superior thoracic paravertebral ganglia of the sympathetic trunks. Postsynaptic fibers travel across cardiopulmonary splanchnic nerves and the cardiac plexus ending in the SA and AV nodes, and they also have connections with the terminations of parasympathetic fibers on the coronary arteries. Sympathetic innervation is needed to increase heart rate, the force of heart contractions, and increase flow through the coronary vessels to support the increased activity. These actions are crucial if you're caught in the wrong neighborhood and are running from a pack of kittens. Parasympathetic innervation, which slows the heart rate and kicks in after you've escaped all those kittens, derives from presynaptic fibers of the vagus nerves. Postsynaptic parasympathetic cell bodies are located in the atrial wall and the intraatrial septum near the SA and AV nodes and along the coronary arteries. Alright, as a quick recap, the heart is a muscular organ located in the mediastinum or thorax between two lungs. The heart has 4 chambers, 2 atria separated by the intraatrial septum, and 2 ventricles separated by the interventricular septum. The right atrium receives deoxygenated blood from the superior and inferior vena cava, and it sends it to the right ventricle through the tricuspid valve, which has 3 cusps that attach to the papillary muscles via chordae tendineae. Then, the blood passes through the pulmonary semilunar valve and reaches the lungs via the pulmonary trunk and its 2 main branches, the left and right pulmonary arteries. The left atrium receives oxygenated blood from the 4 pulmonary veins and then sends it to the left ventricle through the mitral valve, also attached to papillary muscles via chordae tendineae. From the left ventricle, blood is pumped into the aorta through the aortic semilunar valve, reaching the rest of the body. The heart has a conducting system made up of the SA node, located anterolaterally at the junction of the superior vena cava and right atrium, the AV node, located in the posterior-inferior region of the intraatrial septum. Now, on an anterior view, you can see the following structures: the coronary sulcus, the anterior interventricular sulcus, the superior and inferior vena cava, the ascending aorta, and the pulmonary trunk, as well as the ligamentum arteriosum. On a posterior view, you can see the posterior interventricular sulcus, left and right pulmonary veins, left and right pulmonary arteries, the aortic arch, and the superior and inferior vena cava. The heart is innervated by sympathetic and parasympathetic nerve fibers from the cardiac plexus, which is most commonly found on the anterior surface of the bifurcation of the trachea.
Our hearts are responsible for sending blood throughout our body and bringing it back to our lungs in a constant exchange of oxygenated and deoxygenated blood. Here at Osmosis, we also think your hearts are responsible for starting with the heart and showing us love every time you watch one of our videos. But remember, the heart itself also needs its own blood supply, called the coronary circulation, which it gets from the right and left coronary arteries. The coronary arteries are embedded in fat and course across the surface of the heart just deep to the epicardium. Let's begin with the right coronary artery, or RCA, which has its origin in the right aortic sinus and passes to the right side of the pulmonary trunk. Close to its origin, the RCA gives a sinoatrial nodal branch, which supplies the sinoatrial node. The RCA then descends in the coronary sulcus. Along the way, it gives off the right marginal branch, which gets close to the apex but doesn't reach it and supplies the right border of the heart. After giving this branch, the RCA turns to the left and continues its journey in the coronary sulcus posteriorly. Here, the RCA gives yet another branch, the atrioventricular nodal branch, which supplies the AV node. The RCA usually gives the posterior interventricular branch, which descends in the posterior interventricular groove. This branch supplies areas of both ventricles and sends perforating interventricular septal branches into the IV septum. Finally, the terminal branch of the RCA continues for a short distance in the coronary sulcus. The left coronary artery, or LCA, originates from the left aortic sinus and passes between the left auricle and the left side of the pulmonary trunk and gets in the coronary sulcus. At the superior end of the anterior interventricular or IV groove, the LCA divides into 2 branches. The anterior interventricular or IV branch, sometimes called the left anterior descending or LAD, and the circumflex branch. The anterior IV branch passes through the anterior IV groove to the apex, where it turns around the inferior border of the heart and typically anastomoses with the posterior IV branch of the RCA. The anterior IV branch supplies parts of both ventricles and the anterior 2/3 of the interventricular septum through septal branches. In many people, this branch gives rise to the lateral branch or diagonal artery, which descends to the anterior surface of the heart. Now, the circumflex artery runs in the coronary sulcus around the left border of the heart towards the posterior surface of the heart. On its way, it gives the left marginal branch, which also has many tiny branches that supply the left ventricle. Most commonly, the circumflex branch of the LCA terminates in the coronary sulcus on the posterior aspect of the heart prior to the crux of the heart. Okay. To wrap things up, RCA supplies the diaphragmatic surface of the heart, the right atrium, most of the right ventricle, the diaphragmatic part of the left ventricle, and it usually also supplies the posterior third of the interventricular septum, the sinoatrial node, and the AV node. The LCA typically supplies the left atrium, most of the left ventricle, part of the right ventricle, the anterior 2/3 of the IVS, including the AV bundle, through perforating IV septal branches, and the sinoatrial node in some people. And the reason for all the sums and usuallys is because there is something called dominance of the coronary arterial system, which refers to whether the right or left coronary artery gives off the posterior interventricular branch. In 67 to 85% of people, the right coronary artery gives rise to the posterior interventricular branch, so the most common distribution is the right dominant pattern. In this case, the RCA and LCA are each in charge of about 50% of the heart supply. In about 8 to 15% of cases, LCA is dominant and the posterior IV branch comes from the circumflex artery. In 7 to 18% of people, there is codominance, and both RCA and LCA give rise to branches that run in or near the posterior IV groove. And if you thought that all on its own made each of us special, think that some people might have just one coronary artery. In others, the circumflex artery might have its origin in the right aortic sinus. 4% of people have an accessory coronary artery. Finally, the RCA gives the sinoatrial nodal branch 60% of the time and the AV branch 80% of the time, while LCA is responsible for the other scenarios. That's quite some variation. Even though the branches of the coronary arteries are considered to be functional end arteries, the heart does have the potential to develop collateral circulation. This typically occurs between the termination of the right and left coronary arteries in the coronary sulcus between the IV branches near the apex in 10% of normal hearts, and can potentially develop for all hearts. Alright, now where there are arteries, there are veins. So there are heart veins that empty into the coronary sinus, which drains into the right atrium, and some small veins that empty directly into the right atrium. On a posterior view, you can see the main vein of the heart is the coronary sinus, which is a wide vein that runs from left to right in the posterior part of the coronary sulcus. On its left side, on the anterior surface, it receives the great cardiac vein, which is the main tributary of the coronary sinus and drains the areas supplied by the LCA. The great cardiac vein begins as the anterior interventricular vein near the apex of the heart, which accompanies the anterior IV branch of the LCA towards the coronary sulcus. Then it turns left, and this second part of the great cardiac vein runs around the left side of the heart with the circumflex branch of LCA to reach the coronary sinus. Then there's the oblique vein of the left atrium, also called the vein of Marshall, sadly not named after the lovable character from How I Met Your Mother, which is a small vein that descends over the posterior wall of the left atrium and merges with the great cardiac vein to form the coronary sinus. Let's switch gears and look at some more veins on a posterior view of the heart. Here, the coronary sinus receives the middle cardiac vein, which accompanies the posterior interventricular branch, and the small cardiac vein, which accompanies the right marginal artery of RCA. These two veins drain most of the areas supplied by RCA. The left posterior ventricular vein and the left marginal vein also open in the coronary sinus. Some other veins begin over the anterior surface of the right ventricle, cross over the coronary sulcus, and end directly in the right atrium, or sometimes enter the small cardiac vein. Alright, as a quick recap, the heart receives arterial blood supply from the right and left coronary arteries and their branches, and venous blood is drained by the middle cardiac vein, the left marginal vein, as well as the left posterior ventricular vein, part of the small cardiac vein, and the oblique vein of the left atrium. Dominance of the heart refers to whether the right or left coronary artery gives off the posterior interventricular branch, where 67 to 85% of people are right coronary artery dominant. On an anterior view, you can see some of the vessels that supply the heart, such as the RCA and its right marginal branch, a bit of the LCA and the whole anterior interventricular branch of LCA, as well as part of the circumflex artery. You can also see the small cardiac vein following the right marginal branch, the anterior part of the great cardiac vein following the anterior interventricular branch, and finally a small part of the middle cardiac vein. On a posterior view, you can see the left posterior ventricular vein, the posterior interventricular artery, the middle cardiac vein, and the coronary sinus, which collect most of the venous drainage. The breasts, formerly known as the mammary glands, are situated in the subcutaneous tissue overlying our pectoralis muscles. There are many conditions that can affect the breast, the most well-known being breast cancer. Breast cancer, as well as other conditions that can affect the breast, can often go unnoticed, which has serious clinical consequences, so it is important to understand and recognize these conditions as early as possible. So let's start with breast cancer, which causes changes to the structure and appearance of the breasts. One of the classic changes is the presentation of a palpable breast mass, which is typically a hard, immobile lesion with irregular borders, most commonly found in the upper outer quadrants. Another indication of more advanced disease are skin changes, specifically the orange peel appearance, also called the peau d'orange sign, which happens when there's prominent edema and dimpling of the overlying skin. Larger dimpling of the skin can result from cancerous invasion of the glandular tissue and fibrosis, which may also pull on the suspensory ligaments of the breast and can cause retraction of the nipple. If the cancer interferes with the lymphatic drainage, this can lead to lymphedema, which is when there's excess fluid in the subcutaneous tissue. This, in turn, results in deviation of the nipple and the skin appears thickened and leather-like. Cancer cells can spread through contiguity, which is when the adjacent tissue is invaded. When breast cancer cells invade the retromammary space or the pectoral fascia, or when they metastasize to the interpectoral nodes, the breast elevates when the muscle contracts, and this usually signals advanced cancer. Furthermore, the local cancerous invasion to the pectoral fascia and pectoralis major muscle below may result in deep fixation of the breast tissue. Breast cancer usually spreads through lymphatic vessels, which basically carry cancer cells from the breast to the lymph nodes, especially those in the axilla. Communications among lymphatic pathways and among axillary, cervical, and peristernal nodes can cause metastases from the breast to develop in the supraclavicular lymph nodes, in the opposite breast, or in the abdomen, but the most common site of metastasis of breast cancer remains the axillary lymph nodes. Cancer cells can also spread from the breast through venous routes. For example, the posterior intercostal veins drain into the azygous system of veins alongside the bodies of the vertebrae. As a consequence, cancer cells can spread to the vertebrae and from there to the cranium and brain. Breast cancer mainly affects biological females, and it is the most commonly diagnosed malignancy in women in the United States. However, up to 1.5% of cases occur in biological males. In males, the cancer also usually metastasizes to the axillary lymph nodes in addition to bone, pleura, lung, liver, and skin. In male individuals, a visible or palpable subareolar mass or secretion from a nipple can suggest breast cancer. In males, breast cancer tends to infiltrate the pectoral fascia, pectoralis major muscle, and apical lymph nodes in the axilla. Unfortunately, it frequently goes undetected until there are already metastases. A less worrisome breast clinical condition is polymastia, or supernumerary breasts. They are smaller than the usual breasts and consist of only a rudimentary nipple and areola, which can be mistaken for a mole until they change their color during pregnancy. They might even have glandular tissue that can develop during lactation. Supernumerary breasts can appear anywhere along a line that extends from the axilla to the groin. That's because this is the location of the embryonic mammary crest from which the breasts develop and along which breasts develop in animals with multiple breasts, such as female dogs. Now, amastia is when there's no breast development or when nipples and areolas are present but there's no glandular tissue. And finally, polythelia is when accessory nipples are present, just like Chandler Bing's third nipple. Last subject on the breast is gynecomastia, which is a benign proliferation of the breast tissue in biological males, and it is typically caused by an imbalance between estrogenic and androgenic hormones. It is age-dependent, and it most frequently affects males going through puberty, in which case it resolves spontaneously. Less frequently, it affects older males, and it can be caused by liver cirrhosis or testicular cancer, medications like spironolactone, cimetidine, and ketoconazole, among others, and other conditions such as Klinefelter syndrome. Okay, as a quick recap, breast cancer can change the appearance of the breast. Signs include a palpable irregular mass, peau d'orange, retraction of the nipple, lymphedema, and a leather-like appearance. It mainly affects females, though up to 1.5% of cases occur in males. Polymastia is a condition where an individual has an additional, smaller than usual breast consisting of only a rudimentary nipple and areola. Amastia is when there is no breast development, and polythelia is an accessory nipple. Finally, gynecomastia is when breast tissue becomes visibly enlarged in males, and it can happen because of drugs like spironolactone or conditions such as liver cirrhosis or testicular cancer.
The breasts are the most prominent superficial structures in the anterior thoracic wall, consisting of glandular tissue and a supporting fibrous and fatty matrix. This glandular tissue, or mammary glands, are found in the subcutaneous tissue overlying the pectoralis major and minor muscles. The amount of fat surrounding this glandular tissue will determine the size of the breasts. Breasts have a circular body and a nipple in the center, surrounded by a pigmented area of skin called the areola. Each breast has the following boundaries: transversely from the lateral border of the sternum to the mid-axillary line, and vertically from the 2nd through the 6th ribs. 2/3 of the underlying tissue of the breast is formed by the pectoral fascia covering the pectoralis major, and the other third is formed by the fascia that covers the serratus anterior muscle. A small part of the breast might extend along the inferiolateral edge of the pectoralis major, going towards the axillary fossa or the armpit. Here it forms the axillary process or tail, called the tail of Spence. Now, let's take a look at the sagittal section of the female breast. As you can see, there's a fine space between the breast and the pectoral fascia. This is called the retromammary space, or bursa, which is a loose subcutaneous tissue plane. This plane contains a small amount of fat, which allows the breast to move a bit on the pectoral fascia. Breasts contain the mammary glands responsible for lactation in females. Mammary glands are made up of 12 to 20 lobes, each of them containing many smaller lobules. These smaller lobules have grape-like clusters of alveoli that contain mammary secretory epithelial cells, the milk-producing cells of lactation. These alveoli, lobules, and lobes are connected through a network of ducts called the lactiferous ducts, and eventually form unique lactiferous ducts for each lobe, which opens independently to the areola to drain the milk produced during lactation. Each lactiferous duct has a dilated portion deep to the areola, called the lactiferous sinus, in which there's a small drop of milk that accumulates or remains in a nursing mother, which becomes expelled from the areola when compressed during feeding. Next, the stroma of the breast is composed of adipose tissue and fibrous connective tissue. In a non-lactating state, the adipose tissue is situated between the lobes and makes up most of the breast volume. The fibrous connective tissue of the stroma goes on to form fibrous condensations called the suspensory ligaments of Cooper, which firmly attach the mammary glands to the dermis of the overlaying skin. These fibrous connective tissue attachments help support the lobes and lobules of the mammary glands. Moving on, the areolae surround the nipples, which are typically located around the fourth intercostal space, lateral to the midclavicular line, but this varies depending on the size of the breast. Each areola contains a large number of sebaceous glands, which get bigger during pregnancy and secrete an oily substance that acts as a lubricant for the areola and nipple. The nipples are conical or cylindrical prominences in the center of the areola. Keep in mind that the nipples have no fat, hair, or sweat glands. The lactiferous ducts open into the tips of the nipples. Structurally, the nipples are composed of circularly arranged smooth muscle fibers that compress the lactiferous ducts to help express milk during lactation. Now, let's look at the arterial supply of the breast, which derives from several arteries: the medial mammary branches, the lateral thoracic artery, the thoracoacromial arteries, and posterior intercostal arteries. The medial mammary branches come from the internal thoracic artery, which originates from the subclavian artery. The lateral thoracic and thoracoacromial arteries are branches of the axillary artery. The posterior intercostal arteries are branches of the thoracic aorta in the second, third, and fourth intercostal spaces. And finally, the veins of the breast mainly drain into the axillary vein, but some also drain into the internal thoracic vein. Let's move on to the lymphatic drainage of the breast. Basically, lymph passes from the nipple, areola, and glandular lobules to the subareolar lymphatic plexus. From here, most lymph, especially from the lateral breast quadrants, initially drains into the anterior or pectoral nodes, and then to the axillary lymph nodes. Some lymph may drain directly to other axillary nodes, or even to interpectoral, deltopectoral, supraclavicular, or inferior deep cervical nodes. The remaining lymph, especially from the medial breast quadrants, drains to the peristernal lymph nodes or to the opposite breast. Lymph from the inferior quadrants may pass deeply to abdominal lymph nodes, specifically to the subdiaphragmatic inferior phrenic lymph nodes. Lymph from the skin of the breast, with the exception of the nipple and areola, drains into the ipsilateral axillary, inferior deep cervical, and infraclavicular lymph nodes, and also into the peristernal lymph nodes of both sides. Lymph from the axillary nodes first drains into the clavicular lymph nodes, and then into the subclavian lymphatic trunk. And finally, lymph from the peristernal nodes enters the bronchomediastinal lymphatic trunks, which goes on to eventually drain into the venous circulation. Finally, the nerves of the breast come from anterior and lateral cutaneous branches of the 4th through 6th intercostal nerves. The branches of the intercostal nerves go through the pectoral fascia covering the pectoralis major in order to reach the overlying subcutaneous tissue and skin of the breast. The branches of the intercostal nerves carry sensory fibers from the skin of the breast and sympathetic fibers to the blood vessels in the breasts and smooth muscle in the skin and nipple. Alright, as a quick recap, the breasts extend transversely from the lateral border of the sternum to the mid-axillary line, and vertically from the 2nd through the 6th ribs. A small part of the breast might extend along the inferolateral edge of the pectoralis major, forming the tail of Spence. The retromammary space is between the breast and the pectoral fascia, and allows movement of the breast to the structures deep to it. The mammary glands are made up of 12 to 20 lobes, each of them containing several small lobules, which further contain clusters of alveoli that have mammary secretory epithelial cells. The alveoli, lobules, and lobes are connected to ducts that join to form larger ducts called lactiferous ducts, which drain the mammary glands through lactiferous sinuses to the tip of the nipple. The nipples are conical or cylindrical prominences in the center of the areola and have no fat, hair, or sweat glands. The areola are pigmented areas of skin surrounding the nipple. The stroma of the breast is composed of adipose tissue and fibrous connective tissue, which make up the bulk of the breast tissue and support the mammary glands respectively. Arteries of the breast include the medial mammary branches, the lateral thoracic artery, the thoracoacromial arteries, and posterior intercostal arteries. The venous drainage is mainly to the axillary vein, but there is some drainage to the internal thoracic vein. Lymph from the lateral breast quadrants drains to the axillary lymph nodes, and initially to the anterior and pectoral nodes. The remaining lymph, especially from medial breast quadrants, drains to the peristernal lymph nodes or to the opposite breast. Lymph from the inferior quadrants may pass deeply to the abdominal lymph nodes. Lymph from the skin of the breast, with the exception of the nipple and areola, drains into the ipsilateral axillary, inferior deep cervical, and infraclavicular lymph nodes, and also into the peristernal lymph nodes of both sides. The nerves innervating the breast come from anterior and lateral cutaneous branches of the 4th through 6th intercostal nerves.
The abdominal wall is subdivided into the anterior wall, the right and left lateral walls, and the posterior wall. These walls are musculo-aponeurotic, meaning they are composed of muscles and fascial layers, except for the posterior wall, which is also made up by the lumbar vertebral column. This musculo-aponeurotic wall functions to enclose and protect the abdominal viscera, stabilize and contribute to movements of the trunk, and also increase the intra-abdominal pressure which is needed during urination, defecation, vomiting, and assisting in childbirth. Now, the anterior and lateral abdominal walls are collectively known as the anterolateral abdominal wall, mainly because the boundary between the two is not distinct. So the anterolateral abdominal wall extends from the thoracic cage down to the pelvis. More specifically, it's bounded superiorly by the cartilages of the 7th through 10th ribs as well as the xiphoid process, and inferiorly by the inguinal ligament and superior margins of the anterolateral aspects of the pelvic girdle. The anterolateral wall is composed of many different layers. There are 12 of them in total. The most superficial layer is the skin, which covers a superficial fatty layer of subcutaneous tissue, or fat, known as camper fascia, which is a major site of fat storage. Deep to the camper fascia, there is a membranous layer of subcutaneous tissue known as scarpa fascia, which continues inferiorly with the superficial perineal fascia, or Colles fascia. And deep to the superficial fascial layers, there are 3 muscle layers, each covered in a layer of a deep fascia, so 6 layers in total. So right after Colles fascia, there's the superficial investing fascia, followed by the most superficial muscular layer, the external oblique muscle. Then comes the intermediate investing fascia and the internal oblique muscle. And finally, there are the deep investing fascia and the transversus abdominis muscle. Deep to the transversus abdominis is the transversalis fascia. And finally, for our 2 deepest layers, there is a thin layer of extraperitoneal fat which is just above the parietal peritoneum, which is the deepest layer of the abdominal wall and lines the abdominal cavity. So just to recap, let's take a quick break and see if you can recall the layers of the anterolateral abdominal wall. Now let's talk muscles. The external oblique muscle, the internal oblique muscle, and the transversus abdominis muscle are considered the flat abdominal muscles, and the fibers of each have varying orientations. All 3 of these abdominal muscles continue anteriorly and medially as aponeuroses. Aponeuroses are simply flat sheets of fibrous tissue that anchor muscles to bone, deep fascia, or other muscles. The aponeuroses from the left and right flat abdominal muscles fuse in the midline to form the linea alba, which is Latin for white line, and runs from the xiphoid process to the pubic symphysis. The external oblique is the largest and most superficial of the anterolateral abdominal muscles. It originates at the external surfaces of the 5th through 12th ribs and inserts on the linea alba, pubic tubercle, and the anterior half of the iliac crest medial to the pubic tubercle. The posterior fibers of the external oblique are nearly vertical as they travel distally toward the iliac crest. The more anterior fibers, however, fan out medially, making most of the muscular fibers run inferomedially. To remember this, the orientation of the external oblique muscle fibers are in the same direction as your fingers are when your hands are in your pocket. These muscle fibers eventually become aponeurotic around the mid-clavicular line, forming a sheet of tendinous fibers that cross at the linea alba. The inferior margin of the aponeurotic portion also forms the inguinal ligament connecting the anterior superior iliac spine to the pubic tubercle. The muscular portion of the external oblique contributes primarily to the lateral abdominal wall, and the anterior aponeurotic portion contributes to the anterior abdominal wall. The external oblique is innervated by the thoracoabdominal nerves, which are derived from the anterior rami of the T7 to T11 spinal nerves, as well as by the subcostal nerve, which is the anterior ramus of T12. The external oblique flexes and rotates the trunk, like when you're doing those Russian twists at the gym. It also compresses and supports the organs within the abdominal cavity, particularly during expiration. Deep to the external oblique muscles are the internal oblique muscles. Most of their fibers run perpendicularly to the external oblique muscle fibers, so they head infrolaterally. Try giving yourself a hug and placing your hands on your hips. The internal oblique fibers would run in the same direction as your fingers. The posterior portion of the internal oblique muscles originate from the broad connective tissue attached to the spine, known as the thoracolumbar fascia, and also originates from the anterior 2/3 of the iliac crest and tissue deep to the lateral third of the inguinal ligament. The internal oblique then inserts at the inferior border of the 10th through 12th ribs posteriorly and the linea alba anteriorly. It is innervated by the thoracoabdominal nerves, which again are derived from the anterior rami of the T7 to T11 and also by the subcostal nerve and branches of L1 anterior ramus. Similar to the external oblique, the internal oblique muscle compresses and supports abdominal viscera and also helps to flex and rotate the trunk. More specifically, since many of their fibers are actually continuous at the linea alba, the right external oblique and the contralateral left internal oblique would work together to bring the right shoulder towards the left hip. The deepest and final layer of the flat abdominal muscles is the transversus abdominis. Living up to its name, its fibers run transversely, except for the inferior fibers which run parallel to the internal oblique. This muscle originates from a number of structures, including the internal surface of the 7th to 12th costal cartilages, the thoracolumbar fascia, iliac crest, and connective tissue deep to the lateral third of the inguinal ligament. Along with the external and internal obliques, it inserts at the linea alba, as well as the pubic crest. It also has the same innervation as the internal oblique and the thoracoabdominal nerves, subcostal nerve, and the nerves from the L1 anterior ramus. And similar to both oblique muscles, the transversus abdominis helps to compress the abdominal contents in order to increase intra-abdominal pressure, which is helpful during forced expiration, defecation, and labor. Unlike the obliques, though, it doesn't play a role in trunk movement. Besides the flat abdominal muscles, there are also vertical abdominal muscles, namely the rectus abdominis and pyramidalis muscle. The rectus abdominis is a set of vertically oriented paired muscles that lies right at the midline of the anterior abdominal wall and originates at the pubic symphysis and pubic crests and inserts at the xiphoid process and 5th through 7th costal cartilages. It is innervated by the anterior rami of T7 to T12 via the thoracoabdominal and subcostal nerves. The rectus abdominis is a powerful flexor of the trunk, so you can thank this muscle when you do your crunches. It also helps stabilize the tilt of the pelvis, and just like the other abdominal muscles, it compresses the abdominal viscera. The pair of rectus abdominis muscles is separated in the midline by the linea alba, which is a fibrous band composed of interweaving aponeuroses from the flat abdominal muscles. The rectus abdominis is mostly enclosed by the rectus sheath, where the anterior layer of the rectus sheath anchors the rectus muscle transversely by tendinous intersections, which create the bulges seen in people with well-defined abs, or a six-pack. The second vertical abdominal muscle is the pyramidalis muscle, which is a smaller, triangular, or pyramidal-shaped muscle. It lies anterior to the lower portion of the rectus abdominis and originates on the anterior surface of the pubis and inserts at the linea alba. Interestingly, up to 20% of people don't have a pyramidalis muscle, but luckily it is not a critical organ considering its only function is to tense the linea alba. Now, the fibrous rectus sheath is a strong, incomplete aponeurotic covering of the pyramidalis muscle and the rectus abdominis muscle. It also contains the superior epigastric and inferior epigastric arteries, which are an important blood supply for the abdominal wall, as well as other veins, lymphatic vessels, and nerves. The overall function of the rectus sheath is to protect the structures contained within it. The rectus sheath itself is formed from interweaving of the flat abdominal muscles aponeuroses with one another. Now, the rectus sheath is divided into an anterior and posterior layer. However, the rectus sheath is not uniform throughout, so its composition is different in three main areas: above the costal margin, below the costal margin to the arcuate line, and then below the arcuate line to the pubic crest. So, the anterior layer of the rectus sheath above the costal margin consists only of the external oblique aponeurosis. It doesn't contain a posterior layer, and therefore the rectus abdominis lies directly on the thoracic wall. Between the costal margin to just below the umbilicus, the rectus sheath contains an anterior and posterior layer. The internal oblique aponeurosis splits into two layers, or laminae, at the lateral border of the rectus abdominis. The anterior lamina of the internal oblique aponeurosis passes anterior to the muscle and merges with the aponeurosis of the external oblique to form the anterior layer of the rectus sheath. The posterior lamina of the internal oblique aponeurosis passes posterior to the rectus abdominis and merges with the aponeurosis of the transversus abdominis to form the posterior layer of the rectus sheath. Finally, the lower portion of the rectus sheath begins approximately 1/3 of the distance from the umbilicus, or belly button, to the pubic crest. Here, the anterior layer of the rectus sheath is composed of the aponeuroses from all three flat muscles, as the aponeuroses making up the posterior rectus sheath pass anterior to the rectus abdominis, leaving only the transversalis fascia posteriorly. The transition between the thin transversalis fascia covering the inferior quarter of the rectus abdominis and the posterior layer of the rectus sheath covering the superior 3/4 is demarcated by an anatomical landmark known as the arcuate line. Now, can you identify the 3 flat abdominal muscles and the 2 vertical muscles on this image? Next, let's take a look at the internal surface of the anterolateral abdominal wall. The internal surface of the anterolateral abdominal wall is covered with parietal peritoneum. The part of the peritoneum directly below the umbilicus folds into 5 distinct umbilical peritoneal folds, 1 in the median plane and 2 on each side. The fold in the median plane is the median umbilical fold, which extends from the apex of the bladder to the umbilicus and covers a structure known as the median umbilical ligament, which is a remnant of the fetal uricus that originally served to connect the fetal bladder to the umbilicus. Moving laterally on each side of the median umbilical fold, there are the left and right medial umbilical folds covering the medial umbilical ligaments, which are remnants of the fetal umbilical arteries. To remember the median from the medial umbilical folds, think that median means in the middle, so it's the one on the midline. Also, the word medial has an L in it, which should prompt you to remember that it is lateral to the median fold. Moving even further laterally on each side, we come to the last pair of umbilical folds, known as the lateral umbilical folds. These lateral folds are the only ones that don't cover an embryologic remnant, and instead cover the inferior epigastric arteries. So now let's have a look at the sensory innervation of the abdominal wall. The skin and muscles of the anterolateral abdominal wall are mainly innervated by the thoracoabdominal nerves, the subcostal nerve, and the iliohypogastric and ilioinguinal. So first, as we've mentioned, the thoracoabdominal nerves are derived from the anterior rami of the T7 to T11 spinal nerves. Specifically, these nerves are actually the continuation of the lower intercostal nerves distal to the costal margin, where they run in the neurovascular plane between the internal oblique and transversus abdominis. Some of the thoracoabdominal nerves then branch into the lateral and anterior cutaneous branches, which emerge anywhere between T7 and T11. More specifically, the lateral cutaneous branches enter the subcutaneous tissue along the anterior axillary line, in comparison to the anterior cutaneous branches, which enter the subcutaneous tissue closer to the median plane, or midline of the body. The anterior cutaneous branches of T7 to T9 innervate the skin above the umbilicus. T10 supplies the skin at the level of the umbilicus, and T11 innervates a portion of the skin below the umbilicus. Next, the subcostal nerve is the anterior ramus of the T12 spinal nerve, and as the name suggests, it runs along the lower border of the 12th rib before entering the neurovascular plane of the abdominal wall. Similar to the thoracoabdominal nerves, the subcostal nerves also divide into anterior and lateral cutaneous branches, which provide sensory innervation to the skin between the umbilicus and iliac crest. The anterior ramus of the L1 spinal nerve divides into the iliohypogastric and ilioinguinal nerves. The iliohypogastric nerve innervates the internal oblique and transversus abdominis muscles and supplies sensory innervation to the skin overlying the iliac crest, upper inguinal, and hypogastric regions. In contrast, the ilioinguinal nerve supplies the inferior portion of the internal oblique and transversus abdominis and provides sensory innervation of the skin overlying the lower inguinal region, mons pubis, anterior scrotum or labia majora, and medial thigh. The dermatome map matches the distribution of these nerves, where each dermatome begins posteriorly where the spinal nerve exits the vertebral column and generally follows in the direction of the ribs as it wraps around the lateral portion of the trunk to the anterior abdomen. Remember, the nerves, as well as the blood vessels, can generally be found running in the neurovascular plane of the anterolateral abdominal wall, which is the space between the internal oblique and transversus abdominis muscle. Next up, there's the arterial supply of the abdominal wall. First off, there's the superior epigastric artery, which is a continuation of the internal thoracic artery. It descends inferiorly and goes through the rectus sheath deep to the rectus abdominis into the posterior layer and provides blood supply to the superior portion of the rectus abdominis. At the level of the umbilicus, the superior epigastric artery anastomoses with the inferior epigastric artery, which originates from the external iliac artery superior to the inguinal ligament and descends upwards in the transversalis fascia to enter the rectus sheath below the arcuate line. Like the superior epigastric artery, the musculophrenic artery is a terminal branch of the internal thoracic artery. It descends along the costal margin or the rib cage and provides blood supply to the hypochondriac region and anterolateral parts of the diaphragm. The rest of the abdominal wall is supplied by smaller branches. The deep circumflex iliac artery originates from the external iliac artery and provides blood supply to the deep abdominal wall of the inguinal region. The superficial circumflex iliac artery arises from the femoral artery and provides blood to the superficial inguinal region. Another artery that originates from the femoral artery is the superficial epigastric artery, which provides blood to the superficial abdominal wall of the pubic and inferior umbilical regions. Finally, there are the 10th and 11th posterior intercostal arteries, as well as the subcostal arteries, which originate from the aorta and provide blood supply to the lateral region of the anterolateral abdominal wall. And where there are arteries, you know it, there must be veins. So, the skin over the anterolateral abdominal wall is drained by a superficial subcutaneous venous plexus into the internal thoracic vein supromedially, the lateral thoracic vein superolaterally, and inferiorly it drains to the superficial and inferior epigastric veins, which eventually carry the blood to the femoral vein and external iliac vein. Cutaneous veins around the umbilicus anastomose with the paraumbilical veins, which are tributaries of the hepatic portal vein. A superficial anastomotic channel may exist laterally called the thoracoepigastric vein, running between the superficial epigastric vein and the lateral thoracic vein. The deep veins of the anterolateral abdominal wall accompany the arteries, bearing the same names. A deeper, more medial anastomosis can also exist between the inferior epigastric vein, which drains into the external iliac vein, and the superior epigastric vein, which drains into the internal thoracic vein. Finally, regarding lymphatic drainage, the superficial lymph vessels accompanying subcutaneous veins and those found above the umbilicus mainly drain into the axillary lymph nodes and peristernal lymph nodes. Those found inferior to the umbilicus will drain into the superficial inguinal lymph nodes. The deep lymphatic vessels accompany deep veins of the abdominal wall and drain into the external and common iliac lymph nodes, or the right and left lumbar lymph nodes. Alright, as a quick recap, the anterolateral abdominal wall is the area between the thoracic wall and pelvis and is composed of multiple layers of muscles and fascia. The flat abdominal muscles include the external oblique, internal oblique, and transversus abdominis. These muscles eventually become aponeurotic, and these aponeuroses go on to create the rectus sheath. The anterior layer of the rectus sheath is mainly formed by the external oblique and anterior lamina of the internal oblique, whereas the posterior layer is formed by the transversus abdominis and posterior lamina of the internal oblique. A third of the way from the umbilicus to the pubic crest, this posterior layer passes anterior to the rectus abdominis, ending the posterior rectus sheath and leaving only the thin transversalis fascia posteriorly. This transition is demarcated by the arcuate line. This rectus sheath incompletely envelops the vertical abdominal muscles, which are the rectus abdominis and pyramidalis. On the internal surface of the abdominal wall, there are 5 umbilical folds. A median umbilical fold, and on either side of it there are 2 medial and 2 lateral umbilical folds. Between the internal oblique and the transversus abdominis, there's the neurovascular plane that innervates the anterolateral abdominal wall. The skin and muscles of the anterolateral abdominal wall are innervated by the thoracoabdominal nerves from thoracic nerves T7 to T11, the subcostal nerves at T12, and the iliohypogastric and ilioinguinal nerves from lumbar nerve L1. Some of the major arteries that supply the anterior abdominal wall include the superior and inferior epigastric artery, as well as the musculophrenic artery. Superficial lymph vessels above the umbilicus primarily drain towards the axillary lymph nodes, whereas below the umbilicus they drain towards the superficial inguinal lymph nodes. Deep lymph vessels drain into the external iliac lymph nodes and common iliac lymph nodes, as well as the lumbar lymph nodes.
The gastrointestinal tract is essentially a long tube extending from our mouth to our rectum. We rely on it to eat, break down our food, and turn it into, well, you get the picture. Due to its role in breakdown and absorption of nutrients, it's important to understand the different divisions and blood supply of the gastrointestinal tract. The abdominal section of the gastrointestinal tract develops from 3 embryological structures called the primordial foregut, midgut, and hindgut. And in turn, the foregut, midgut, and hindgut all derive from the 3 embryonic germ layers, the endoderm, mesoderm, and ectoderm. The mesoderm is what forms the peritoneum, which either completely or partially lines the organs of the peritoneal cavity, including the gastrointestinal tract. It's important to understand these different embryological divisions, as the foregut, midgut, and hindgut each have their own unique blood supply. The foregut extends from the esophagus to the duodenum, at the level of the major duodenal papilla, where the pancreatic and common bile duct insert, and it consists of the esophagus, stomach, the proximal duodenum, as well as the liver, gallbladder, pancreas, and spleen. The midgut extends from the distal portion of the duodenum to the last third of the transverse colon. It consists of the distal duodenum, jejunum, ileum, cecum, appendix, ascending colon, and proximal 2/3 of the transverse colon. Finally, the hindgut extends from the distal third of the transverse colon to the anal canal, above the pectinate line. It consists of the distal portion of the transverse colon, descending colon, and sigmoid colon, and rectum. Now remember that organs with the same embryologic origin share the same arterial supply, which primarily comes from the abdominal aorta and its single anterior branches: the celiac trunk for the foregut, the superior mesenteric artery for the midgut, and the inferior mesenteric artery for the hindgut. The celiac trunk arises from the anterior wall of the abdominal aorta at the level of the 12th thoracic vertebra and the aortic hiatus of the diaphragm. It has a short course, going anteriorly and inferiorly for less than 2 centimeters before branching into 3 arteries: the left gastric, splenic, and common hepatic arteries. The left gastric artery ascends where it gives the esophageal branch, which supplies the distal portion of the esophagus. Then, it curves downwards along the lesser curvature and within the lesser omentum, giving smaller branches that supply the anterior and posterior walls of the stomach, and it also anastomoses with the right gastric artery. The splenic artery travels to the left within the splenorenal ligament, a ligamentous connection between the spleen and left kidney, along the superior border of the pancreas, and it gives branches for the body of the pancreas, a posterior gastric branch, and a branch for the hilum of the spleen. At the hilum of the spleen, the splenic artery gives short gastric arteries for the fundus of the stomach, and the left gastro-omental or gastroepiploic artery. That descends along the greater curvature of the stomach and supplies the wall adjacent to it. Finally, the common hepatic artery goes towards the porta hepatis, which is a small but deep transverse fissure through which all the neurovascular structures of the liver pass. The common hepatic artery separates into 2 main branches. The first branch is the gastroduodenal artery that descends behind the first part of the duodenum and gives 2 more major branches. First is the right gastro-omental or gastroepiploic artery, which enters the greater omentum and passes along the greater curvature of the stomach to supply its walls and to anastomose with the left gastro-omental artery. The second branch is the superior pancreatico-duodenal artery, which soon divides into anterior and posterior branches that descend in front and behind the head of the pancreas, respectively. These branches supply the head of the pancreas as well as the proximal part of the duodenum. After giving the duodenal artery, the common hepatic artery continues as a hepatic artery proper, and on its way to the liver, it gives the right gastric artery. This artery runs along the lesser curvature of the stomach, supplying its walls and anastomosing with the left gastric artery. Finally, the hepatic artery proper branches into the left and right hepatic arteries, which supply the liver. The right hepatic artery also gives a branch called the cystic artery that goes within the hepatoduodenal ligament to supply the gallbladder and cystic duct. So, in essence, the celiac trunk, through its branches, supplies all the structures of the foregut. Let's take a quick break and try to identify the main branches of the celiac trunk, as well as the regions that they supply. Moving on down the abdominal aorta, at the level of the L1 vertebra and about 1 centimeter inferior to the celiac trunk, is the superior mesenteric artery, or SMA. The SMA branches from the abdominal aorta posterior to the neck of the pancreas, and as it travels inferiorly, it emerges anteriorly and medially to the uncinate process of the pancreas. It also crosses anterior to the left renal vein and the third part of the duodenum. The SMA runs through the layers of the mesentery and goes towards the ileocecal junction in the right lower quadrant, giving many intestinal branches along the way. The first one is usually the inferior pancreatico-duodenal artery that gives anterior and posterior branches to the duodenum and anastomose with the anterior and posterior branches of the superior pancreatico-duodenal artery of the celiac trunk. Then, the SMA gives around 15 to 18 intestinal branches to the jejunum and ileum. These adjacent intestinal branches form anastomoses with each other that look like loops, called the arterial arcades. From these arcades arise many straight arteries, called the vasa recta, that supply and penetrate the intestines. Branches for the jejunum have fewer and larger arcades with longer vasa recta, while the ileum has more arcades with shorter loops and shorter vasa recta. Next, the SMA gives off the ileocolic artery, which supplies the cecum and parts of the terminal ileum and ascending colon. It also gives the appendicular artery that goes within the mesoappendix and supplies the appendix. The SMA also gives rise to the right colic artery that travels retroperitoneally to supply the ascending colon. Lastly, the SMA gives off the middle colic artery, which ascends retroperitoneally within the transverse mesocolon to supply the transverse colon. Last but not least, going back to the abdominal aorta now, the inferior mesenteric artery, or IMA, arises at the level of the L3 vertebra, from the anterior wall of the abdominal aorta. The IMA gives off the left colic artery, that goes retroperitoneally to the left and supplies the descending colon. Next are the sigmoid arteries, that travel within the sigmoid mesocolon to supply the sigmoid colon, as well as a part of the descending colon through anastomoses with the left colic artery. The last branch of the IMA is the superior rectal artery, that supplies the proximal part of the rectum via the left and right branches that follow it retroperitoneally into the pelvis. Some of its branches anastomose with the sigmoid arteries as well. Let's take another break and see if you can identify the main branches of the superior and inferior mesenteric arteries. Now, looking at the blood supply of the whole large intestines, from the cecum to the rectum, we can see that all adjacent major arteries, including the ileocolic, right, middle, left colic, and sigmoid arteries, share anastomoses with each other. This gives rise to the marginal artery, which runs the entire length of the colon close to the mesenteric border, and provides adequate blood supply for the colon. Specifically, the right colic and middle colic artery anastomose to supply the right colic flexure, and the middle colic artery connects to the left colic artery to supply the left colic flexure. This anastomosis at the left colic flexure marks the connection between the SMA and IMA, allowing the marginal artery to provide continuous blood supply to the intestines from both SMA and IMA in the event of reduced blood flow in either one of these arteries. Finally, the rectum is supplied by three different types of arteries: the superior, middle, and inferior rectal arteries. The superior rectal artery arises from the IMA and supplies the proximal part of the rectum. The middle rectal arteries arise from the internal iliac arteries and supply the middle and distal parts of the rectum. The inferior rectal arteries arise from the internal pudendal arteries and supply the distal part of the rectum, anorectal junction, and anal canal. Finally, the superior, middle, and inferior rectal arteries can also form an anastomosis with each other. Now, let's switch gears and look at the venous drainage of the abdominal viscera. First, let's discuss how there's both a systemic venous drainage system and a portal venous drainage system. The systemic venous system occurs when venous blood drains from a single capillary bed and has a direct course to drain into either the inferior or superior vena cava, which returns blood to the right atrium. In contrast, a portal venous system occurs when blood travels through two different capillary beds, which is what venous blood from the small and large intestines do. So venous blood from the small and large intestines drains into the superior mesenteric vein and the inferior mesenteric vein through their first capillary bed in the intestines. These veins, along with the splenic vein, come together to drain into the hepatic portal vein, which is part of the portal venous system, and goes on to drain into the liver. The hepatic portal vein allows nutrient venous blood from the small and large intestines to filter through the liver to be absorbed and processed before entering the systemic venous system. Therefore, this blood first drains from the capillary bed of the intestines into the hepatic portal vein as a part of the portal venous system to the liver, then filters into a specialized secondary capillary bed known as the liver sinusoids. From here, blood drains into the central veins of the liver, which ultimately drain into the hepatic veins and subsequent IVC as part of the systemic venous system. Regarding the anatomy of the hepatic portal vein specifically, this vein arises when the superior mesenteric vein and splenic vein merge, around the level of the L1 vertebra and transpyloric plane, behind the neck of the pancreas and in front of the inferior vena cava. The inferior mesenteric vein contributes to the portal system as well, most commonly draining in the splenic vein, but may sometimes drain into the superior mesenteric vein instead. Less commonly, it can drain directly into the junction of the superior mesenteric and splenic veins. Alright, as a quick recap. The primordial foregut gives rise to the esophagus, stomach, proximal duodenum to the level of the major duodenal papilla, liver, gallbladder, pancreas, and spleen. The midgut gives rise to the distal duodenum, jejunum, ileum, cecum, appendix, ascending colon, and proximal 2/3 of the transverse colon. The hindgut gives rise to the distal third of the transverse colon, descending and sigmoid colon, and rectum. The foregut is supplied by the celiac trunk, which comes off at the level of T12 and gives off the left gastric artery, the splenic artery, and the common hepatic artery. The midgut is supplied by the superior mesenteric artery that arises from the abdominal aorta at the level of L1 and crosses the left renal vein and third part of the duodenum. The SMA gives the inferior pancreatico-duodenal artery, intestinal arteries that form arterial arcades, the ileocolic artery, the appendicular artery from it, as well as the right and middle colic arteries. The inferior mesenteric artery arises from the abdominal aorta at the level of L3 and gives the left colic artery, sigmoid arteries, and the superior rectal artery. Along the colon, arteries anastomose as well, forming the marginal artery that connects to SMA and IMA. Venous blood from these organs is collected into the superior mesenteric vein, inferior mesenteric vein, and the splenic vein that together form the hepatic portal vein that drains into the liver. The inferior mesenteric vein drains into the splenic vein, or, less likely, into the superior mesenteric vein.
Before you start watching this video, relax and take a deep breath. Think about the air filling up your lungs, which are located on either side of your thoracic cavity. Now, we often take breathing for granted because it's under autonomic control, and it's not until we have trouble breathing when we realize just how important our lungs are. There are many conditions that can affect the lungs, which can have a huge impact on our day-to-day lives. Let's look at some causes for lung ailments, starting with injuries of the cervical pleura and the lung apex. Both of these structures project through the superior thoracic aperture into the neck. So when there's an injury involving the base of the neck, the lungs and pleural sacs can be injured as well, which can cause a pneumothorax. The pleura is also exposed to potential injury in its inferior portion because it descends below the costal margin in 3 regions, where penetrating injury may enter into the pleural sac. The first is the right part of the infrasternal angle. The other 2 parts are the right and left posterior costovertebral angles, which are inferomedial to the 12th ribs and posterior to the superior poles of the kidneys. So kidney surgery can pose a risk for pleural injury. When discussing injuries to the pleura and lungs, it's important to understand what pleuritic chest pain means. Pleuritic chest pain is caused by irritation to the pleura, which results in the classical sharp stabbing pain that gets worse when you breathe in and is exacerbated even further by deep inhalation and exhalation. Pleuritic chest pain can have multiple causes, including a pneumothorax, which is when there's air trapped within the pleural cavity, or a pleural effusion, when fluid builds up in the pleural cavity. Inflammation of the pleura can result in pleuritic chest pain, which is often the result of infection or inflammatory diseases such as rheumatoid arthritis, and may even result in an empyema where infected fluid builds up in the pleural cavity. Pulmonary emboli can also result in irritation of the pleura, resulting in pleuritic chest pain. Pleuritic chest pain is mostly experienced at the site of pleural irritation. However, we can also have a phenomenon we call referred pain. Portions of the parietal lung pleura are innervated by branches of the intercostal nerves peripherally and the phrenic nerves centrally, where the parietal pleura covers the diaphragm. So, for example, if there's irritation of the parietal pleura caused by something like an infection or effusion overlying the mediastinal and central areas of the diaphragm, then we get referred pain to the dermatomal areas supplied by the same spinal levels. So in this case, the central diaphragm is innervated by the phrenic nerve, which is supplied by spinal levels C3, C4, and C5. So the dermatomes of the same spinal levels C3, C4, and C5, which innervate the root of the neck and shoulder, could result in referred pain to the neck or shoulder. Now let's look at a procedure called a thoracentesis, also known as a thoracocentesis, which is when a hypodermic needle is inserted through an intercostal space and into the pleural cavity to remove pleural fluid, blood, or pus from the pleural space. With a thoracentesis, the needle can be inserted between the 6th and 8th rib on the mid-clavicular line, between the 8th and 10th rib along the mid-axillary line, or between the 10th and 12th rib along the paravertebral line. Always remember to insert the needle above the superior border of the rib in order to avoid damage to the intercostal nerves and vessels, which run along the inferior portion of each rib. For example, if doing a thoracentesis at the mid-axillary line between rib 8 and 9, you would insert the needle along the superior border of the 9th rib as your guide. To enter the pleural cavity, the needle passes through skin, then the intercostal muscles, and finally the costal parietal pleura. If the individual sits in an upright position, the intrapleural fluid accumulates in the costodiaphragmatic recess due to gravity. In this case, the needle should be inserted into the 8th or 9th intercostal space in the mid-axillary line during expiration, which will help avoid injuring the inferior border of the lung. Additionally, the needle should be oriented upward in order to avoid penetrating the deep side of the recess, which is a thin layer of diaphragmatic parietal pleura and diaphragm overlying the liver. Of note, caution should be taken as any thoracentesis done below the 9th rib has a risk of injury to abdominal structures, like the liver, if doing a thoracentesis on the right lung. Okay, now just a few words on pneumothorax. Air can accumulate in the pleural cavity because of a penetrating wound in the parietal pleura, such as a bullet or knife wound. The lungs are particularly vulnerable at the apices as the cervical pleura extends above the first rib and clavicle. However, a pneumothorax can also occur spontaneously, in which case it's termed a spontaneous pneumothorax. No matter the cause, when there's air in the pleural cavity, this can present with varying degrees of severity, depending on the extent of the pneumothorax. Symptoms of a pneumothorax include shortness of breath and sudden unilateral pleuritic chest pain. On clinical examination, the chest wall on the affected side might appear bigger than the normal side. On palpation, chest expansion is uneven due to decreased chest wall movement of the affected side, and tactile fremitus is decreased on the affected side. On percussion, the extra air in the pleural space causes hyperresonance on the affected side, and breath sounds are diminished on the affected side. On a chest X-ray, there's a retracted visceral pleural edge, which is seen as a thin, sharp white line, alongside a decreased lung volume due to the lung collapsing. The space beyond the visceral line is mostly black because the space where the lung should be is filled with air. When there's only a small amount of air in the pleural space, the individual is usually hemodynamically stable and can be treated conservatively. However, a larger pneumothorax can result in significant collapse of the corresponding lung and requires advanced treatment. A pneumothorax can also escalate into what is known as a tension pneumothorax, where air continues to enter the pleural space and is unable to leave. This is because with a tension pneumothorax, there's a flap of tissue close to the area of air entry that creates a one-way valve for air to flow in the pleural space, but does not allow air out. A tension pneumothorax typically has a more severe clinical presentation. See, that's because air can't get out, so it rapidly accumulates in the pleural cavity, compressing the other organs in the mediastinum, including the heart, leading to increased thoracic pressure, which causes lower systemic venous return to the heart and a decreased cardiac output. Other clinical signs include increased heart rate and breathing rate, distended neck veins, and distant muffled heart sounds. With a tension pneumothorax, there may also be a mediastinal shift on a chest X-ray, which is seen as a tracheal deviation and displacement of chest structures away from the affected side. However, a tension pneumothorax should be recognized clinically and treated immediately to achieve decompression, since it can cause rapid deterioration of vital signs. So typically, the quickest way to allow for air evacuation is needle thoracostomy, which is often done in the second intercostal space on the affected side, at the mid-clavicular line, which decompresses the chest and provides an escape route for the trapped air. Since anatomy always comes in handy, you can identify the second costal cartilage by using the sternal angle. Once you locate the sternal angle, the intercostal space below it is the second intercostal space, which you can follow by palpation to the mid-clavicular line for needle insertion. Alternatively, you can also use the fourth or fifth intercostal space at the mid-axillary line for decompression. Following needle decompression, a thoracostomy tube is typically placed. Speaking of which, chest tubes can be used for a variety of other reasons as well. Right off the bat, a chest tube is a good idea when air, blood, fluid, pus, or a combination of these accumulates in the pleural cavity. In this case, the chest tube is inserted in either the fourth or fifth intercostal space at the anterior axillary or mid-axillary line, and then guided through the skin, subcutaneous tissue, serratus anterior, intercostal muscles, and parietal pleura. In order to safely do this and prevent injury to surrounding structures, we use the triangle of safety, which is formed anteriorly by the lateral border of the pectoralis major muscle, posteriorly by the lateral border of the latissimus dorsi muscle, and inferiorly by a horizontal line from the nipple or fifth intercostal space. So the preferred area for chest tube placement is at the mid-axillary line in the triangle of safety, and this is done in either the fourth or fifth intercostal space, depending on situational and patient factors. Additionally, the tube should also be placed in the inferior portion of the intercostal space to avoid injury to the intercostal neurovascular structures coursing along the inferior ribs. The tube can be directed superiorly toward the cervical pleura for air removal, for example when there's a pneumothorax, or directed inferiorly toward the costodiaphragmatic recess when fluid needs to be removed. The end of the tube that's outside the body is then connected to an underwater drainage system to prevent air from being sucked back into the pleural cavity. Now, let's take a breather and focus on where we can best hear the lungs. Let's remember some anatomy facts on the lungs. To locate the different lobes of the lungs, we can trace out the lung fissures using anatomical landmarks. In both lungs, the oblique fissure runs posteriorly at the level of T3 to the sixth rib anteriorly at the mid-clavicular line. The horizontal fissure, which separates the superior and middle lobes of the right lung, connects to the right oblique fissure at the mid-axillary line near the fifth rib, and runs anteriorly to the area of the fourth costal cartilage. This shows us that when auscultating, most of the posterior auscultation will be examining the inferior lobes, where the anterior auscultation is mostly examining the superior and middle lobes. Auscultation of the lungs is very important for clinical examinations, as it allows assessment of airflow through the tracheobronchial tree. Auscultation should be done sequentially from the apices of the lungs to the base of the lungs, comparing the left and right lung as you move distally, and listening to multiple places on both the anterior and posterior chest. The lung apices can be auscultated in the root of the neck above the inner third of the clavicle. The superior lobes of the lungs are best heard when the stethoscope is placed anteriorly in the second intercostal space on the midclavicular line. Moving inferiorly, the middle lobe of the right lung can be heard around the fourth intercostal space along the midclavicular line, while auscultation of the fourth intercostal space over the left lung would still be examining the left upper lobe. The inferior lobes can be heard anteriorly in the sixth intercostal space on the mid-axillary line and posteriorly between T3 and T10. Finally, the base of the lung is best heard over the posterior thoracic wall at the level of the 10th thoracic vertebra. Okay, now let's switch gears and look at clinical correlates regarding the tracheobronchial tree. Remember that the trachea bifurcates into two main bronchi at the level of the sternal angle. The right main bronchus is wider, shorter, and has a more vertical trajectory than the left one. Because of this, aspirated foreign bodies or food are more likely to enter and lodge in the right bronchus or one of its branches. Now, when an individual aspirates, they are at risk of developing aspiration pneumonia. Because of gravity, aspiration pneumonia is most likely to occur in the dependent lung segments. Which segment is the dependent segment depends on the individual's position. In the supine position, the dependent lung segments are the posterior segments of the upper lobes and superior segments of the lower lobes. Individuals in an upright position will most likely develop aspiration pneumonia in the basilar segments of the lower lobes. Finally, when lying on the right side, aspirate usually enters the right upper lobe. And finally, sometimes lung resections may be needed in clinical practice, which is when parts of the lungs need to be surgically removed. Now remember that there are about 10 bronchopulmonary segments for the right lung and 8 to 10 for the left lung, as some of the segments may be combined. So if tumors or abscesses are located in a single bronchopulmonary segment, they can be surgically removed through a segmentectomy. If an entire lobe needs to be removed, it's called a lobectomy. And if the entire lung needs to be removed due to a disease process, this is called a pneumonectomy. A particular type of tumor is the apical lung tumor, also known as a Pancoast tumor, which is typically a non-small cell lung cancer. This cancer develops in the apex of the lung near the superior sulcus, which can go on to infiltrate or compress nearby structures. One such structure is the stellate ganglion, a sympathetic cervical ganglion, which is a collection of sympathetic nerves that supply the face or the arm. Compression or infiltration leads to Horner syndrome, which has 3 distinct features: a constricted pupil, called miosis, due to interruption of the sympathetic fibers innervating the dilator pupillae muscle, leading to unopposed parasympathetic innervation; partial ptosis, or a drooping of the eyelid, due to loss of sympathetic control of the superior tarsal smooth muscle of the upper eyelid; and anhidrosis, or impaired sweating, due to dysfunction of the sweat glands of the face. If the tumor compresses the brachial plexus and subclavian vessels, also known as thoracic outlet syndrome, it can cause symptoms which include arm muscle weakness and paresthesia, similar to Klumpke palsy, as well as ischemia and pain due to vascular compression. Sometimes this tumor can compress the phrenic nerve, in which case it can lead to hemodiaphragm paralysis. It can also compress other structures, such as the recurrent laryngeal nerve, causing hoarseness of the voice. It can compress the superior vena cava, leading to superior vena cava syndrome, which impairs blood drainage from the upper limbs and the head and neck, leading to venous congestion of these areas, resulting in venous engorgement, redness, and edema, as well as headaches and dizziness. Compression can also occur at the brachiocephalic veins draining into the superior vena cava, causing similar symptoms as superior vena cava syndrome, but only on the side of the body which they drain. Also, due to the size of these tumors, dysphagia might be present due to local invasion. Oh, look at the time. It's quiz o'clock. Can you remember what a thoracentesis is and where it's performed? Also, Does this chest X-ray show a regular or a tension pneumothorax? All right, as a quick recap, a thoracentesis can be done to remove blood, pus, or to obtain a pleural fluid sample from the pleural cavity. It requires that a needle be inserted between the 6th and 8th rib in the midclavicular line, the 8th and 10th rib along the mid-axillary line, or between the 10th and 12th rib along the paravertebral line, and the needle is always inserted superior to the rib to avoid injury to the intercostal neurovascular structures. With the pneumothorax, there are varying amounts of air in the pleural cavity, leading to a range of symptom severity, while with a tension pneumothorax, the air is trapped in the pleural cavity, so presentation is usually more severe. On a chest X-ray with a tension pneumothorax, the trachea is deviated towards the unaffected side. Air evacuation is done by inserting a needle or chest tube in the space between the 2nd and 3rd rib of the affected side at the midclavicular line, or in the 4th or 5th intercostal space at the mid-axillary line, or placing a chest tube. A chest tube is also used to drain fluid, blood, pus, air, or a combination of all of these from the pleural cavity. It's inserted in the 4th or 5th intercostal space in the mid-axillary line. Foreign bodies are usually aspirated into the right main bronchus and lodge into one of its branches. Tumors and abscesses of the lung can be partly or entirely surgically removed, depending on their location. Finally, an apical lung tumor, known as a Pancoast tumor, can cause a variety of clinical conditions as it can compress on nearby structures, such as the subclavian vessels and brachial plexus, phrenic nerve, recurrent laryngeal nerve, superior vena cava, the brachiocephalic veins, and stellate ganglion.